It's been one week I've been here, but actually outside it's really because of the electric. Yeah. It's so much. That's the thought. I was having breathing or something. So very good. Yeah. You get used to the driving. And so you see that you found in eyes already. The teaching. When we came there today, it's just so the argument that before when I was like it's even still carols and lots of people yeah lots of distance. Just a little bit. Okay. Yes, right, wait. Okay. Okay. Okay. Distinguished guests, colleagues, and participants, I extend my sincere greetings and welcome you to this important event. Good morning, everyone, and welcome to the second day of the conference. It's a pleasure to open another exciting day filled with insightful talks and groundbreaking research in pediatrics and child health. I would like to thank the organizers and express my gratitude to all attendees for being here today. We have an excellent lineup of distinguished speakers and foster presenters today, each contributing their expertise to advance our understanding and improve outcomes for children worldwide. With your permission, I would like to invite the speakers to share their scientific and practical knowledge with us. Let me, okay. Now, I would like to invite, with your permission, the first keynote speakers, Dr. Linda Abu Jaber from Jordan, a board-certified pediatrician and pediatrics infection disease specialist. Welcome, Mrs. Yeah.
Good morning, everyone. I'm Dr. Linda Abu Jaber, and I'm board certified in pediatrics, in pediatric infectious diseases, and in holistic and integrated medicine. So as you can see, I'm one of those people that likes to learn new things and collect information because I think it's fun. I became an integrated medicine doctor as a result of my own challenges and my children's challenges. And what integrated medicine means is we take the best of Western medicine and the best of traditional medicines like homeopathy, hypnosis, nutrition, Ayurveda, Chinese medicine, all these things, and we mix them together. And we use evidence-based information. So today I wanted to talk about the art of medicine rather than talk about the science, because many of you have talked about the science of medicine. But my real question is, in this day and age where there's ChatGPT, where everything is available online, what is our job as a pediatrician or as a doctor? I mean, it's nice to know all about epigenetics, but what does epigenetics mean to a mother or to a father? What does eat a healthy diet mean? I had a woman, I always like to do locum tenens in faraway places, like in poorer places. And a Mexican mother asked me, she said, you know, Dr. Linda, you're telling me to eat healthy food, but what exactly does that mean? And that kind of stopped me in my steps. I thought everybody knew what healthy food was. I thought everybody knew what exercise was. I thought everybody knew how important sleep was. But it turns out people don't. We live in this high tower of knowledge that we know a lot of stuff, while 60% of children are developing chronic diseases. Um, Depression has doubled in teenagers and children. Anxiety has doubled in teenagers and children after the COVID. After the COVID vaccine came out and we started seeing all these side effects, people are very suspicious of doctors. So I find that what we really need to do is now start bridging the gap again between us and the moms and the dads. And that's only going to be done through spending time with them. And the medical way to spend time with people is through well baby checks, well child checks. And that's why this talk, how do I change these slides? Why this talk to me is very important. I started out my medical practice thinking I was going to save the world through fighting disease. And then the older I got and the more advanced I got in medicine, I decided fighting disease wasn't really the point. Because when I finished my practice in America in 2013, at least half of my patients were having behavioral problems, depression, sleep problems, and eating problems, ADHD type symptoms. And I couldn't figure out why I went from being a pediatrician to being a psychiatrist. And that's when I really started realizing the importance of teaching parents. And I know as pediatricians, we always laugh, we love children, but the parents are a problem. Why don't we start looking at things a different way? Why don't we start looking as parents as the solution to a lot of the world's problems? And the only way to do that for me is through educating them, teaching them what a healthy diet is. How do you make a kid eat broccoli when they don't want to eat broccoli? How do you make a 3-year-old go to sleep when my son, for instance, would do this when when it was bedtime, he refused to sleep. So how do you teach parents to deal with their children who don't want to do what we know is best for them? And that, I think, is where the art of medicine comes in. Too many times, too many doctors have told me I'm constantly looking at my computer. I never get to connect with the patient and with the mother. And that's actually true. And again, my relationship with my patients, I left America 15 years ago. They still call me up. And my little kids that I used to take care of will call me up and say, Dr. Linda, what do you think I should do? And that's not because I'm a brilliant teacher. It's because I would talk to them like a mom. I would say, you know, my kids wouldn't eat well. My son refused to sleep. I mean, I had postpartum depression. And when you speak to parents as if you understand where they're coming from, just like you talked about, we need to connect before we redirect. We need to connect to our mothers and the parents before we try to redirect them to do all these epigenetic changes in their lives, before we convince them to give vaccinations when they don't believe us. So that's my little soapbox talk. Now to the talk. Why does the talk matter? 1 in every 6 children in the worldwide has either a developmental or behavioral delay. Do you realize how many kids that is? And in the Middle East, in the MENA region, it's 16 to 27% of children have these problems. And a lot of them, I think, are due to our cultural practices and our parenting beliefs in the Middle East. Because we'll talk about that in a minute. So most delays are missed before age 3, and 50% of the delays could have been found at 18 months if somebody were looking for them. So when we do a well baby check and we teach the parent, this is what your child should be doing. They become part of the team instead of part of the problem. They can come to us and say, you know, Dr. Linda, you said this should be happening, or this should be happening, or this should be happening, and it's not. Is that a problem? And that is a moment of contact. It's a moment of how are we going to connect to these people and teach them what they need to know. Often moms will come into my office, their babies are 8, 9 months old, and they say they're not sitting up. And I say, well, how much time do they spend on the floor? And they say, oh, I don't put my baby on the floor because it's dirty or because I don't want them to get cold. They don't realize how important tummy time is. How do you, like, for instance, they'll say, my baby isn't babbling. First question I ask is, did you hear the hearing screen? People say, Well, I didn't do the hearing screen because my kid seems to hear, not realizing that there's all sorts of different frequencies. The baby could only be hearing very high notes. We need to be able to really know exactly what this child is going through before we start evaluating their development and their health. Like a little baby comes in and they're not babbling and they didn't sit up. I did a full exam. The baby was neurologically normal. I said, did you check the hearing? They said no. And I found out that this little girl who I'd seen for the first time was 6 months old. She couldn't hear. And, there's a relationship between hearing and between balance and motor development, because sometimes the hearing loss, which is 1 in 3 children are born with hearing loss, and 2 to 3% of these kids actually have severe hearing loss. These kids can also have problems in their inner ear. So developmental delay can be part of not being able to hear. And it's a shame for us to lose that. I mean, can you imagine the mother is coming to you and she's crying and you just think that maybe she's not a good mother, or you only have the 5 minutes to spend. This is why well baby checks are so very important. Okay, that didn't work. Okay, so what I want to do with this is explain why well baby exams are essential, and I think I've kind of gone through that. I want you to recognize cultural factors in the MENA region, if any of you are living in the MENA region or working in the MENA region, because we have specific cultural beliefs and things that we do that are passed down from mother to grandmother. I remember posting on my Instagram page that you shouldn't give Yensun. Yensun is, who can tell me what Yensun is? It's aniseed, the tea that they give to babies to calm colic. 2 or 3 babies have gone to emergency rooms with seizures because their mothers drank too much tea and they were breastfeeding. And I put that on the internet. I said, you have to be very careful about doing that. And I got lots of hate mail. We've been doing it for years and years, and we've never had any problem. And I say, but look, I have to educate you so that when you do something, you know the science and what the side effects are potential. And then you can make a decision when you know exactly what is going on. Okay? So what exactly is a well baby check? It's regular stuff. We do the head circumference, the height, the weight. But we should also do a developmental screen on babies. We should do developmental screens at the same time that we give the vaccinations, because that is our chance to find out, A, if the baby has any developmental delays. B, it's to teach them how is breastfeeding supposed to go? How is sleep supposed to go? I mean, when I was growing up as a doctor, I never had a sleeping consultant, behavior consultant, all these subspecialists. I had to do it all. And it was kind of nice because I got to know my patients. I got to know how the mother was interacting with the baby. I got to know exactly what was going on. And I knew that if the baby, things weren't going well, that she would come back to me and we could figure it out together. Because I find a lot of times now people go to doctors, especially in the MENA region. You go the first time, the problem isn't solved, they go to somebody else, and then they go to somebody else. And kids are very delayed in their development, like that doctor yesterday who talked about the child with chronic abdominal pain that had been to 15 different doctors and had 1,000 different tests. Most likely, if this person had come to one doctor and they did follow up, they would have reached the decision a lot sooner and things wouldn't have gone so far down the drain. So it's about building relationships. It's also about immunizations. I don't know if you see what's going on in America, but everybody's against immunizations now. Nobody wants to give the MMR. So now we're going to start seeing measles. I mean, and this is all based on pseudoscience. There's no science that says measles, mumps, and rubella should be given individually. Actually, because I'm an infectious disease doctor, you're supposed to give the MMR and the varicella vaccine separately, because when you give them together, there's a higher incidence of febrile seizures. But at the second dose, you don't need to do that. That's actually the true science behind that. And now everybody's running around, where am I going to get the measles vaccine? Where am I going to get the mumps vaccine? Where am I going to get the rubella vaccine? And it's causing panic that's not necessary. I mean, if you can take a few minutes and actually talk to somebody who trusts you, we can help. We can maybe stop us from seeing polio again and measles again and, all these nasty diseases that we don't see anymore. So 80% of growth, I know you know all this. The science you're very, very good with. 80% of brain growth happens before the age of 3, which is why the first 1,000 days is so tremendously important. And 50% of developmental issues can be identified, like I said, by 18 months. And as we all know, when we have early detection, we feel better, right? As doctors, don't you feel good when you discover something before it becomes an issue? The parent trusts you. I didn't realize that my baby might not be crawling because they're never on the floor, or I shouldn't swaddle my baby like this because it might cause congenital hip delay, or I shouldn't put salt on my baby when they're first born because it might cause seizures and give them a nasty case of some sort of dehydration or another. I shouldn't put kuhal in my baby's eyes because there's lead in kuhal and lead kills brain cells, because a lot of younger moms like you guys are trying to talk to the grandmothers and the grandparents and the mother-in-law. And you need to have science to talk to the parent and say, I don't want you to put corn in my baby's eyes because it might kill brain cells. You have something to work with. And if she doesn't want to listen to you, you can go to your husband and talk together. So a lot of you have grown up with cell phones. I see most of you are on your cell phones, not even listening to what I'm saying. So how are we going to teach children how to interact with each other if we're not interacting? I'm up here with a microphone and you're not listening to me. How are you going to teach kids how to talk to their husbands? How are you going to teach the kids how to talk to each other? I mean, a lot of the problems in the world right now are from lack of connection. I mean, in parenting, you connect and then you redirect. I know I've said that before, but how can you connect if you don't have the time? If you're only seeing babies when they've got a high fever, if you're only seeing them when they're having vomiting or diarrhea or when they're dehydrated. Okay, so what matters for you is it builds trust, number one. Okay, it builds trust in you and it builds trust in yourself. I always felt really good when I discovered something before it became a problem. And I could teach the mother what to do. Even in my clinic today, put your baby on the floor, take the kofet, the tight swaddle off. Don't use sugar and water for the baby with high bilirubin. Or you don't put garlic around their neck because that doesn't really do much for the bilirubin. And they might get tetanus from the dirt. These are cultural practices we have in this area. And of course, it increases children's health. I mean, I didn't like becoming a psychiatrist for kids. I really like treating illnesses. I have a few board certifications. I really like doing stuff. But the real need right now is to make our children healthy, and that's through making parents more aware, to teach them, to connect with them. So let's say the cultural realities in the MENA. Co-sleeping is very common in the MENA region. What does co-sleeping cause? What is it a risk factor for? Parents don't realize that. They think it's just warm and cuddly and snuggly. How about salting a baby? The babies can get hypernatremia. Gender expectations, like a lot of times they think that boys walk earlier and they talk later. And then, or teething. I think we're going to go into a few of those because I was kind of surprised at these two. So the positive practices in the Middle East, it's nice that there's extended family, but I can't tell you the number of girls who come to me and say, I wish my family would leave me alone. They all have an opinion. Everybody says something different. I can't take this anymore. And I say, look, come to me. I'll give you the information. I'll tell you how to talk to your husband so you both can talk together, because I think this is really important. But did you realize a lot of kids come in, and I don't know what it's like in Azerbaijan and other places, but when a kid comes in swaddled like this, did that happen? Because it happens in Jordan, for instance, in the Middle East. And that can cause developmental hip dysplasia. We have a very high incidence of developmental hip dysplasia. Is it genetic? Possibly, a lot of it. But if you tightly swaddle a baby and they can't move their legs, they can't develop their hips. So it's really important to find out what people are doing at home. If you don't put the kid on the floor, how are they going to crawl? If you don't talk, like a lot of people don't realize that children, even at 1, can feel the trauma of the parents. When they're going through a divorce, they say, oh, the kid doesn't understand, but they're crying all the time. And you have to explain to them that the kid's crying is because they feel the tension in the air and they're not comfortable. And they go, oh, so maybe and so I tell them, because I did trauma informed care too, like maybe you should hold them more and calm them down and touch them, give them quiet time during the day because they really feel the tension that's in the air. Even though you think they don't understand the words, they don't, but they do understand the energy. And there's science behind that. There's electromagnetic field that comes out of our heart, and they've done studies that there's actually, what's the word I'm looking for? When the waves start to work together, like your brain waves, when they're like this, the babies will become like this. I can't remember the word for that. But you see, again, I'm a mother and hopefully a grandmother one day, so it's all right not to know the exact words because I'm not trying to use the scientific term to intimidate parents. I'm trying to get them to understand why they need to do certain things because medicine should be a lot about coaching now. Because kids are coming to you, well, I saw that on ChatGPT, and I'll say that you know how to use it, you know? Because everything's out there on ChatGPT, right? Or whatever, Gemini or whatever. Our job is to interpret and to help people, at least until we're completely replaced by AI. In the meantime, I think humanity is very, very important. Like fathers aren't involved. Do you know that when fathers are involved in raising the baby or in the baby from the time the baby is in the uterus, babies are healthier, breastfeeding is more successful, children have better vocabulary, and the boys have better behavior and less behavioral problems at the age of 3. Did you realize Did you realize that the heart rate and the pupils dilate when the baby gets excited when the father plays with it, even at a very small age, where the baby calms down. So the baby needs both people involved. And then there's a lot of shame around developmental delays. Parents sometimes, if you don't, they won't tell you something isn't working right, or they think their baby's delayed because everybody judges them. I was doing rounds at the university the other day, and I asked the mother what was wrong. She started to cry. I said, what's wrong? She said, everybody's judging me because my baby has a parasite. And we live next to a farm where there's cows and chickens. And I said, but he's 18 months old. He's going to be running around. She said, I know, but everybody's looking at me and blaming me because my kid is sick. That woman just needed a little bit of connection. I said, it's all right. Kids are going to eat a lot of dirt. Here are some habits that you might want to take up, like washing the hands, cutting the fingernails. So once she felt like she was heard and understood, she was a lot more willing to listen to what we had to say. I mean, you got to give these nasty medications when kids have parasites, right? Telling them just to make the kid take it isn't going to be very helpful when the kid's going to go like that, right? Okay, so I'll give you a couple of. I told you about Layla, where somebody missed the hearing loss. One of the most prominent cases, I saw a little 2-month-old, just for a well baby check, because I talk to parents about doing well baby checks, and they come to me, and I examine this baby, and she had bilateral cataracts that had been missed at birth. So the first doctor to see her. Now, we were able at 2 months to get the cataracts extracted because I asked the mother, first off, what happened was I was using the black and white and the baby wasn't following with their eyes. And I thought, wow, that's kind of interesting. And then I went to the physical exam part, and baby couldn't, she had the leukocoria. So we got that taken care of. Here's a really sad one. Noah was 4 years old, and she went to the pre-K because they put kids in school very early here. And and everybody was talking about how stupid she was and she couldn't learn. And I said, let's take a step back. How does your baby sleep? Baby couldn't sleep. Had never gotten sleep training, which is something we teach in well baby checks, yes? At 2 months, what to expect. At 4 months, when to stop the feeding at night. Kids are feeding at night till 3 years of age. Do you guys realize that? And the mothers are exhausted. They're having another baby. And we talked about the epigenetics of having the epigenetics of a baby that was born to a mother in stress. Remember yesterday, the telomeres are shorter? It's horrifying. or diabetes or something like that. If people really knew what their behavior meant in a gentle way, not don't eat that because it's not good for you, but in a gentle way, it's a lot easier to change behaviors. Am I done? Or do I have some more time? I don't know how much time I have. So in terms of parental beliefs, like a lot of times here in Jordan, they believe that if you teeth early, you're going to walk late. So I had Ahmed came to me. He was 18 months old. He started getting teeth at 6 months, but he couldn't walk. And I said, well, what's the deal? She said, well, my parents told me that he teethed early, so he was going to walk late. Turns out he had stiffness in his legs. He had a little bit of cerebral palsy, and it was affecting his legs. We got him into physical therapy so then he could sit and then he could walk a little bit better. This is a bad one. MMR causes autism. Influenza vaccine causes influenza. I don't even wait for parents. I just now, when I'm doing the vaccine talk, I go immediately into what are their fears. When you anticipate what their fears are, you can actually connect with them and then you can guide them toward the right answers. And I had a person the other day, I wrote a book on vaccines in Arabic because I think it's tremendously important. It's up on my website. It's called Al-Mut'aim. I called it a very, very creative name, vaccines. But it's the only one. And then what I did was I went through each vaccine and I said, here's what the vaccine is. Here's what it's made out of. This is why it's safe during pregnancy. This is why it isn't. Do you know that, I'm sorry, I'm asking you guys a lot of questions, that most mothers don't realize that they should get the DTaP with every pregnancy? And so their baby is exposed to whooping cough after they're born during the winter. They don't realize that they can get the RSV monoclonal vaccine now to protect their babies who are born in winter. You know, it's because we're, again, as a pediatrician, I thought I wanted to go into to save the world, you know, fighting one disease at the time. But really what I want now is to make us all more healthier, make us all be able to look each other in the eye again and see human beings and help each other. You know, it does take a village to raise a baby. You know, a lot of parents, we're talking about obesity. A lot of parents, the minute the baby starts to cry, they stuff a bottle in its mouth, not realizing that there are other cues. I'm hungry, I'm bored, please leave me alone. You know, I need a little bit of time to myself. I need sleep, please. And that's actually something I learned from my son. I was, you know, all gung ho. I was a new pediatrician and I was board certified, by the way. And my son came, and whenever he'd do this with his eyes, instead of knowing that he was sleeping, I would start stimulating him. I ended up with a baby that didn't sleep for 3 years. So that's why sleep is one of my passions, is because honest to God, he would go like this so that he wouldn't fall asleep. And that was a mistake that I made as a pediatrician. I never wanted to go to the classes on well baby checks because what do I do with well babies? I want to deal with DKA. I want to deal with, you know, cancer. I want to fix all these things. But thankfully, that's not what most kids are. But we're starting to see more of that because people don't know how to prevent it. Okay? So, in terms of reframing the visit, for you, it's about I want to get to know you. I want to get to know your baby. Do you have postpartum depression? Do you know the effects of postpartum depression on babies? Postpartum depression causes attachment disorder. Moms can't, if they can't attach to themselves and calm themselves down, they can't attach to the baby. The baby ends up with colic. Babies have twice the number of upper respiratory infections when the mother has postpartum depression. Did you know that fathers get postpartum depression? 25 to 50% of men whose wives have postpartum depression get postpartum depression, but they're not diagnosed. They're angry, they don't want to talk to their wives, and they avoid the house. So that's when the divorces happen. Instead of somebody realizing this guy is just going through a very hard time and looking at him. And I've diagnosed quite a few dads with postpartum depression. And people go, no. And I say, yes, let's find him a man to talk to that will help him through this transitional phase. Let's check his iron. Let's check his vitamin D. But you can't do these things when you don't know who you're talking to and you're talking at them and they don't trust you. Okay? So, as an integrative doctor, because I do homeopathy, I do hypnosis, I do energy medicine, I'm a shaman, and I've got 3 Western board certifications. The way I bring it together is this. It's all, everything it's supposed to end to health. The microbiome, the Arab doctors said that before anybody else said that. The Chinese doctors also said that. So we need to first look, like we said, at the diet. Teach parents, give your kids probiotics in the form. My daughter used to suck pickles. Okay? She really did. And I didn't realize what she was looking for until I started learning about the microbiome. I thought, why is this kid sucking pickles? And then I realized that that was an issue, and that was her way of getting it. I had to teach parents in America how to make yogurt because they didn't have unsweetened yogurt. So I would give these recipes. How do you add high iron foods? You gotta give a recipe. Make them a little mjadara. Cook some hadas with some brown rice, for instance. Okay? And I know it's not sexy, but there's nothing more gratifying than being part of a family and them coming up and seeing you in the grocery store and saying, Dr. or whatever your name happens to be, because you actually have impacted their family. And you don't just, see, this is the thing. As we learned in epigenetics, you're not just impacting the family, you're impacting the next generation and the generation behind that, because epigenetics is proving that. So when you're a good grandma, you're being a good mom, you're teaching the mom, you're teaching the kid, and then the next generation that comes along, they have the best knowledge that we can give. Plus, if any of you work with insurance companies, even if you charge more for the well baby check, you're saving them money in emergency visits. You don't have to run to the doctor every time the baby gets a fever for you, but that takes time to teach people. What are the signs of dehydration? So the minute the kid does a little bit of reflux, you're not running to the hospital. This is where we can teach parents about health. We can teach them how to parent the child in a better way, so that we're not messing them up. Because often what happens is we parent the way we were parented. And I remember when my children were little, I would say, something would come out of my mouth and I'd say, I promised myself I'd never say that. What the heck is wrong with me? So I started long before it was sexy to do conscious parenting and to do preventive medicine. I started doing it. And you know what? Some days I would sit in my clinic and feel really sad because there weren't a lot of people. And then I'd remember, but that was my point. Because during sick season, when everybody came sick, they would come to me. But during healthy season, they just give me a call and say, what should I do? And I'd say, just do that. You don't need to come in. And that is the type of relationship that I have enjoyed with my patients. And I hope that all of you get to enjoy that too, instead of looking at your computers and your phones all the time, because life is about connection and relationships. I have a couple free tools, like for parents. If you guys want them, you can contact me on my Instagram or my WhatsApp. And for doctors, 3 culturally adapted screening questions, because as we know as doctors, it's not, the quality of the answer is defined by the quality of the question. If we don't ask the right question, we're not really going to get the answers. We're going to get parents who are testing us to see if we really know what we're doing. Do you have that? And then, okay, so like I said, just validate what your parents are telling you. Say, it's all right. This is, you have to, just like with parenting a toddler, you get down to their level, not physically, but you tell them you understand that this is what happened, and you try to redirect them into the place that you want to go. And then everything will start getting better. For the key takeaways, well baby visits are prevention, they're not routine. I used to spend 45 minutes with my patients. Cultural context does determine impact. Small early actions, like you take the cataracts out of a baby with congenital cataracts, changes their life forever. Or you deal with postpartum depression, and then you have a kid that can attach to their parent very thoroughly and not have anxiety or depression later on. And try to empower parents. I always used to have handouts written in my office because I give a lot of information. I do know that. But and people started using them. They would use them, they would send them from one person to the other. They wouldn't call me up, they'd say, well, I have your handout that you gave to so-and-so. So to make life easier for you, if you want, So make well baby check standard, integrate screening tools in your clinic. If anybody's interested, I'm creating some culturally adapted, like in Arabic. I don't speak Azerbaijani, I'm sorry, or Turkish, but in Arabic, I'm making some tools to modify the MCHAP, which should be done at 15 to 18 months. Please don't forget to do that in your well baby checks. And so I'm making a toolkit for the MENA region because sometimes the things you don't know are the things that hurt you and the baby most. So again, we want to avoid, we want to prevent harm, and let's turn awareness into action. This is my, these are all how to find me. And I hope to hear from you guys. And if you're interested in that toolkit, send me a WhatsApp message. And my number is on my Instagram.
Thank you.
Does anybody have any questions?
Yes.
Oh, then.
I want to ask you. What about the vaccinated, the monovirus infections? You know, this is very common between the children. And what age we should vaccinate is?
You start at 4. You want to do it less than 8 months. Yeah, and you can start at the 2 months.
What's the name?
The rotavirus?
Yes.
There's rotarix, there's 2 of them. Yeah, so there you give the vaccine by mouth, just like you gave the polio. You need to warn the parents that the child may get a little low-grade fever and they might have diarrhea and a couple of vomitings after that. Yeah, it shouldn't be a high temperature, but some kids, I mean, I have some kids that come to me, they always get a 40-degree temperature, and they never do the 38. We all have one of those, right? The minute they get a fever, it's 40 degrees, 41 degrees. But no, it's important to warn them because it is a live and attenuated virus. So it's important to warn mommies of that. Well, 2 months and 4 months, and then the latest age you want to give it is 8 months. So you can't give it after 8 months of age. And depending on it, some need two, and some you have to do 3. Usually it's about 6 to 8 weeks between them. Thank you. You're welcome. There's a young lady over there. Yeah.
So just 18 months, that should be done as well.
The MCHAP. Yeah. That's the screening, that's the screening for autism.
So you don't get to feel that connection with the young child after just 6 weeks visit. So how would you encourage us to incorporate that? Because I know you said the relationship there is good, but then you can look at it.
Do you have health visitors over in Ireland?
We do, yeah.
Well, they do a tremendous amount of what Linda does.
Yes.
So, you're doing the role of I would say about 5 other professionals.
Well, I was in a small town in the middle of nowhere in the United States, and I had to be, I'm 2/3 of an infection. I'm 100% of infectious disease. I'm 2/3 of a gastroenterologist, 2/3 of a pulmonologist, because the closest tertiary hospital was 6 hours away. So I was on my own. So maybe I was lucky, but what you do is go and talk, go to the family doctors, go to the older pediatricians and sit with them. And you'll see what that's like, because it's really important. And then again, when you are in your own practice, when you're done with stuff, you can say, I want to incorporate well baby checks into my clinic. You get to spend more time, but you also get to spend more money. And it's so much more fun to play with babies than it is to deal with them when they're vomiting and having rashes. That part's fun. The well baby checks, if you do 1 or 2 a day, that's fun. But think about it, that one check, the mother will talk to somebody else because moms talk to each other. They'll say, this doctor took that time with me, and I think you should go see her. You see? And then that's how you build relationships. Does that answer your question?
I think the most, many amazing things about your talk, but I didn't realise the sort of cultural differences. And I think we assume as professionals that everybody knows what we know
Mhm.
and how it works in our country, but it's really interesting. Yeah.
Shocked. When I came back, I thought, people still salt their kids? What are they, turkeys? You know, it's actually, they're very common practices. Some people in Saudi Arabia put, bat blood on their babies. Bat blood. And you know, in America, bat blood carries rabies. It seems in Saudi Arabia it doesn't, or it hasn't been picked up and kids are dying of SIDS when it's actually rabies. I don't know. But you see, I mean, and then that's why we need to, you know, when you explain to a parent, I mean, I know they've been doing it for 10,000 years, but they may not have caught the case of rabies that killed the baby. You know what I mean? And then you just plant that seed. Because change starts one person at a time.
I'm a mother and my friends are mothers. Some of us have given birth to our children in the States or Canada or the Arab world, Dubai, whatever. And then we all have different vaccine cards for our children. And I have friends that moved from the UK to Dubai, and then the pediatrician in Dubai said, give your child this vaccine. And they go back to the British, for example, vaccine card, and they're like, but this is not on my British vaccine card. Which one do I go with? Is there a chance that we can maybe standardize vaccines for children? I feel like we have this huge debate between ourselves. Do we give the RSV? Do we give the flu shot? It has egg whites. It has, I don't know what it has. What age do I?
Let me answer the egg thing, because that's one of my favorites. There's no more egg in influenza vaccine that's given individually. The egg is in the one that's multiple dose. So if you have a child where you're worried about egg weight or egg, you ask to give the individual dose. Influenza is a dead piece of protein that causes the immune response. So influenza, while the vaccine might give you muscle pain, it might give you, you know, I don't feel very good, and the baby might not feel good, but it will not give you influenza. It saves lives. It stops the people from being in the ICU, even though it doesn't. You see, this is important. Vaccines don't always completely prevent the disease. It just attenuates it. You know, like RSV, you can get RSV, but you won't get the RSV that puts you on a ventilator. You won't get the RSV that puts you in the ICU and in the hospital.
In Canada, those are optional, in Jordan, they're mandatory, in other parts, there are certain vaccines that in the States, they can choose to give it or not to their child.
Well, there's certainly the DTaP, the Hib, the Prevnar, the rotavirus are all mandatory. Why? Because these diseases are more severe in children less than 2 and less than 5. And this is why we start giving the vaccinations early, because a 2-month-old that gets Prevnar could die from it. An older kid that, you know, they can get the pneumonia, they can get the meningitis. But after 5, it's not as severe until you get to a little bit older than I am. And then we got to start taking the pneumococcal vaccine again. Hepatitis B, I always gave people the freedom. If the mother's hepatitis B negative, you can wait and do the hepatitis B at 2, 4, and then 18 months. However, if you're in a daycare, for instance, where there's a child who bites, and that baby is a carrier of hepatitis B, because people say, well, hepatitis B is transmitted via blood and via sex. But how about saliva from a person who has it, whose mother had it, that didn't get the vaccine? You see, there's nuances there. But I would give everybody hepatitis B. I would give the vaccine of the papilloma virus, HPV. People say it's sexually transmitted. Yeah, but kids now are becoming sexually active a lot earlier than they used to be. So it's really important that we catch them. I mean, kids are starting to have sex at 11 and 12. You know, and because this internet and all these crazy people on the internet, we need to give this vaccine because it prevents cervical cancer, you know? And it's a costly vaccine. Kids might faint after getting the vaccine, okay? But you know what? Fainting the one time is way better than getting cancer when you're 50 years old. You see? Because there's a lot of discussion, and that's why I wrote the book. You know, here's the vaccine, but the RSV is a new one. We used to give RSV to preemies, and it had to be once a month, and it was like $2,000 or $3,000 a dose. Now it's a one monoclonal vaccine. It's good for the whole season, and you usually don't need to give it again. And it's for all kids born during RSV season, because you see, vaccines change, life changes quickly, and some doctors just don't have the time to keep up with it. I'm curious about stuff like that, and I wrote a book about vaccines, so I keep up with it. So I think I've taken up enough time. Just put this down. Okay. Put my glasses on to hide my head. Oh, no touching? Thank you very much.
Pediatric eating speech studies. Current healthy staff learn multidisciplinary approaches to speech and feeding therapy for children with autism spectrum disorders. Please welcome Mr. Shaban for me. Okay, can we follow the from this?
Hello, it's honor to me being here. It's okay. Thank you. A multidisciplinary approach to speech and reading development in autism spectrum disorder. This is one slide. Sorry, this is one slide. Slide one. Slide two. Critical domains in early child neurodevelopment, speech and feeding development are two of the most critical domains. These areas are often intertwined with sensory, cognitive, and behavioral factors in children with autism spectrum disorder. Defining in child in autism spectrum disorder is a neurodevelopment condition characterized by deficit in social communication and restricted interests. 60 to 89% of children with autism spectrum disorder present with feeding difficulties. Examples: food selectivity or aversion and sensory-based refusal. The impact of difficulties, feeding issues compromise nutritional states and restrict social participation, DL speech, and oral motor control, hinder expressive communication and social integration. Interventions targeting both speech and feeding are inseparable from the broader developmental framework. The gold standard, multidisciplinary collaboration. The multidisciplinary approach is essential due to the interconnectedness of systems. The team, speech language pathology, focuses on articulation and swallowing. Occupational therapy addresses sensory modulation and posture. Psychology manages behavioral rigidity and family stress. Family training ensures home-based continuity. Early intervention and neuroplasticity. The first 6 years of life are the critical window for rehabilitation. Synaptic density and neural adaptability are at the peak. Therapies must integrate sensory, motor, and emotional inputs during this sensitive phase. Sensory foundation, occupational therapy role. Children with autism spectrum disorder exhibit sensory processing difference classified by Dunn's sensory processing framework. These include hypersensitivity, hyposensitivity, or sensory skilling behaviors. Occupational therapy uses sensory integration therapy to regulate these responses, creating a stable sensory foundation for oral motor skill development. Blending behavior and emotion. Applied behavior analysis, ABA, principles contribute to structured interventions. Modern approaches blend with developmental and family-centered frameworks. This blend ensures emotional safety alongside necessary skill execution. Family involvement and generalization. Family training is a critical predictor or long-term outcomes and home career. Key strategies, parental modeling, emotional attunement, and consistent home practice. Collaborative good settings ensures consistency and motivation across all contexts. Methods, research, and clinical design. Model, integrated clinical model applied to children with autism spectrum disorder, 8 to or 8 years. Duration, 12-week structured therapy program. I don't good English. My son helped me. Hı hı. Evet, İngilizcem çok iyi olmadığı için oğlum bana yardım etti. Ben buradan çeviriyorum ama oradan. Evet, doğru. Hı hı. Pardon. Sen bana yardımcı olur musun? Hı hı. Basal enhancement tools, oral motor, and feeding skills checkers. Sensor profile, childhood autism, writing skills, parent-child interaction, observations sheet. Şimdi çevirdim orada da. Clinical application, SLP, and oral motor integration. Therapy is based on the oral motor continuity. Sessions use Beckman oral motor techniques for severe oral evasion, non-nutritive stimulation. Clinical application, SOS feeding protocol. Feeding therapy followed the sequential oral sensory approach. Method emphasizing graded exposure to food through play. Stepwise interaction, look, touch, smell, taste, eat. Occupational therapists addressed postural stability and interoceptive cues. Parent coaching and relationship centered philosophy. Parents received coaching focused on reading child cues during feeding and speech attempts, modeling a positive emotional tone during meals, avoiding first feeding or overcorrection. The emotional climate during feeding directly affects oral motor learning. Results, quantitative progress. After 12 weeks, quantitative scoring indicated a 35% improvement across oral motor and feeding scales. Observed progress. Increased lip closure, tongue, movement, precision, and chewing rhythm. Improved while consonant squeezing and articulatory clarity. Reduced food refusal and sensory evasion. Discussion. Interdependence of systems. The improvements underscore the interdependence of sensory, motor, cognitive, and emotional systems. Significance occupational therapy, psych, occupational therapist, sensory regulation, focus, created the foundation. Psychology, reduced meal time, anxiety. Therapeutic success, yes. Burada. Hayır, burada. Şuradayım, therapeutic success depends not only on targeted exercises, but also on relation and contextual harmony. Conclusion and key implications. Integrated practice, SLP, must align with occupational therapy and psychological input for emotional readings. Sensory foundations addressing sensory regulations is fundamental for articulation and mealtime participation. Family empowerment, parents must be regarded as co-therapists. Their emotional attunement is critical. Therapist celebration, regular case discussions, and joint sessions enhance efficiency and conscientiousness. In short, solving the speech and feeding problems of a child with autism requires a team consisting of a speech therapist, occupational therapist, and psychologists working together in collaboration with the family. Thank you for listening. I tried my best. Answer the questions my son had to me. Yes, questions? Yes, okay.
Except to eat one type of food. Can you give a practical way to see, like, he only wants to eat pizza, but we need to get some vegetables and things in the child's diet.
Diyor ki yani mesela o sadece pizza yemek istiyor ama başka şeyler de yemek istiyor. Onun için nasıl bir yardımcı oluruz? Sebze falan.
Anladım. Şimdi şöyle SOS feeding terapi ile biz destek oluyoruz. SOS feeding'in ilkelerine göre ben aynı zamanda SOS feeding terapi ile yardımcı oluyoruz.
We help with the SOS feeding therapy.
SOS feeding'in ilkelerine göre
In SOS feeding therapy rules,
önce ergoterapist, occupational therapy,
first occupational therapy,
psikolog,
physical health,
psychologist,
psychological health,
onların güvenini, tat, koku ihtiyaçlarını karşılıyoruz, özgüvenini karşılıyoruz.
We tried to how can I say give them for their self-respect and they trust for themselves, and we're trying to give them those things, and when they have those things, they start eating more kind of things.
Önce odaya alışır, terapiste alışır, olduğu yere alışır, terapiste alışır.
First, he get used to when he eats.
Mekanda olabilir bu. Mekana da diyebiliriz.
Therapist rooms.
Sonra dokunmayı öğrenir, eline alır, koklar, sonra yüzüne dokundurur, dudaklarına dokundurur, ağzına alması için dokuyu hisseder. Ondan sonra oral motor desteğini vermiş oluruz.
First, dokunuyor.
Hı hı.
First touch, smell, like they try to feel the food, and then in their mouths, and then get used to slowly, and they get started to eating.
Bu arada eğer çocuklar eğer çocuklar herhangi özel gereksinimli birey veya otizm tanılı bireyse mutlaka öncesinde oral motor terapiye ihtiyaç varsa Beckman prompt terapileriyle önce desteklenir, ondan sonra bu anlattıklarımız aynı zamanda da multidisipliner yaklaşım. Yani sadece konuşma terapistiyle değil ya da beslenme uzmanıyla değil. Aynı zamanda ergoterapist, özel eğitim uzmanı, hareket eğitimi uzmanı ve burada adlandırmadığım doktorlar mutlaka, çocuk doktoru, bunların hepsinin birlikte olan bir yaklaşımıyla alınacak bir sistemdir. Yani multidisipliner sistemle yaklaşmamız gerekiyor veya mutlaka ailelerin de desteği bulmalı. Şöyle ve bütün bu terapiler ailelerin gözlemiyle devam eder ve ailelere de öğretilir. Aileler mutlaka gözlemler biz çalışırken. O gözlemde çalışma sisteminin içerisinde aile öğretilir. Ama sistem şöyledir. Her bir anne babanın çocuğuyla duygusal bir bağ vardır ya. O duygusal bağı koparmadan aynı zamanda o sistemi de, bu yüzden bütün terapistlerin birlikte çalışması önemlidir. Ve en önemli de zaten en önemlisi de oral motor sistemde, eğer özel gereksinimli bir bireyle çalışıyorsak oral motor sistemde ihtiyaç varsa ergoterapist ve psikologların desteği olmadan ağız içine, hepimizin mahremidir ağız içi, oraya müdahale edilmez. Önce dokunma, koku, tat, hissi en son. Ergoterapist, duyu bütünleme uzmanı, occupational terapist, psikolog, oyun terapisti desteğiyle 0-6 yaş grubunda oyun terapisi desteği alırız genel olarak. Onun dışında oyun terapisinin içinde çocuğun kaygıları, güveni, onları oluşturmuş oluruz. Ve ergoterapistlerle de o dokunma, koku, tat, hassasiyetleri, zaten onları bilmeden herhangi bir sistemin içerisinde biz bir de Rus ekolüyle olan oral motor sistemle ilgili olan çalışmaları da konuşma terapistleri, diğer Avrupa konuşma terapistlerinden farkımız bundadır bir de. Çünkü bu sistemi daha iyi biliriz ve daha iyi çözebiliriz o konuşmayla ilgili olan sistemde, oral motor sistemde. Önce yüz, dudaklar, sonra ağzın içi. Ağzın içinde yanak, sonra damak, en sonunda dile dokunuyoruz. Çünkü logopedler bu sistemi bilir.
Okay, thank you for this good presentation. This way it will rock. So she published. Yeah. Esas yaxşı bir tane teşekkür ederim. Allah bilir, teşekkür ederim. Orada bizim teknikler. The speaker is Dr. Fraser Anderson from Canton and postdoctoral research for our doctor. whose work focused on physiological and behavioral mechanism in pediatric allergies. The presentation is titled Distinct Allergic Specificity for Class T Cell Immune Response and Part and Novotel Association for Pediatric COVID allergic types.
Thank you for the introduction. Good morning, everyone. So I'm Tracy. I'm coming from Qatar. I work in Citra Medicine as a postdoctoral fellow in the Department of Translational Medicine. So today I'll be talking to you all about the prevalence of distinct allergen-specific CD4 T cell immune responses and gut microbial association that prevail in pediatric cow milk allergies. So I don't have any financial disclosures. So talking about allergies, the first thing that we have to understand is the term immunological tolerance. Immunological tolerance is a state of non-responsiveness to self-antigens or innocuous external antigens. So this is the identification of Tregs has been awarded the Nobel Prize for Physiology or Medicine this year. So it was for the Tregs. So these Tregs play a significant role in allergies. So as I said, it is providing a state of non-responsiveness to harmless antigens. But when there is a failure to mount effective immune response or effective tolerogenic immune response to the harmless antigen, there occurs chronic inflammatory disorders which are called allergic diseases. So, and allergic diseases could be mainly of two different types. They are called the IgE-mediated allergies or the non-IgE-mediated allergies. The IgE-mediated allergies are immediate hypersensitivity reactions, whereas the non-IgE-mediated allergies are delayed hypersensitivity reactions. So the first one occurs within even within 15 minutes, but the other one probably takes days or even weeks to manifest. So in terms of IgE-mediated allergies, the role of antigen-specific, there are specific Tregs that are specific for the allergens, which are called the antigen-specific Tregs. And also there are conventional T cells which are formed in response to the allergens, which are called antigen-specific T-cons. So in terms of aeroantigens, it has been previously shown the importance of regulatory T cells and also in other types of IgE-mediated food allergies. But in case of non-IgE-mediated allergies, this has what is the underlying immune response that causes allergic diseases has not been very well characterized. In terms of IgE-mediated the thing that is happening is that there are a particular type of CD4 T cells known as the Th2 CD4 T cells which undergo high or there occurs an expansion of the Th2 cells as opposed to the Tregs, and this imbalance can cause allergic response in IgE-mediated allergies. But in non-IgE-mediated allergies, what is happening is not known. So in this study, I'll be discussing about this aspect. What are the factors that affect immune tolerance? So there are genetic factors, environmental factors, and dietary factors which influence allergies. The genetic factors include the familial history of allergy, which whether the mother, grandparents, father, or anybody has allergy, there is a predisposition to develop allergy in the children. And also there are several factors. The mode of delivery, it is said that the vaginal delivery actually promotes immune tolerance. And whether the baby is breastfed, whether the baby is living in a joint family or not, whether they are exposed to antibiotics or probiotics, all these during their the first 1,000 days of life, like as you said, is very important in a baby's life. So during this time, whatever is a baby exposed gives a predisposition to the development of allergy. So if all these factors, which is the vaginal delivery, joint family, all these actually promotes immune tolerance, whereas, for example, the baby is exposed to too much of antibiotics. Even the mother is exposed to too much of antibiotics. It can cause a dysbiosis in the microbiome and leads to a tendency to develop allergy in the child. And as I said, there is an imbalance in immune tolerance. You can see the Tregs would be higher than the Th2, but then when there is allergy, the Th2 responses are higher than the Tregs. So this is particularly in case of IgE-mediated allergies. Now, as I said, when there is a diverse microbiome, what happens is that when an antigen, the allergen basically can be called as an antigen. So this antigen is being presented by an antigen presenting cell. For example, a dendritic cell is an antigen presenting cell. So that presents it to a naive CD4 T cell and directs the naive CD4 T cell to differentiate into Treg type of lineage, and that promotes tolerance when there is a diverse microbiome. But when there is a microbial dysbiosis, when the antigen presentation occurs, it causes the naive CD4 T cell to differentiate into a Th2 type of lineage, and then causes the downregulatory, the Ig-mediated allergic response. So this is in the context of IgE responses. But again, as I said, in non-IgE, this is not very well characterized. Now moving on to food allergies, like we know that there are different types of food allergies and peanut, cow milk, shellfish, etc. But cow milk allergy is something that a child is being or more prone to because they are exposed to milk from very early in life, like formula milk, etc. Even before 1 year of age. So there is more tendency in children to develop cow milk allergies. And we see that there are like around 21% of children living worldwide has cow milk allergy. So here, as I mentioned, there are different types of cow milk allergies as well, IgE and non-IgE mediated allergies. So in our study, what we did is, so I'm working in a hospital, which is a maternal and child health hospital. So we recruit subjects from the hospital itself. So we have these children who were presented with allergies. From them, we collected patients who were having so we had 4 different categories. We had a control population who were the non-allergic children. Then we had an IG-mediated allergy group, which were presenting with the typical IG allergies. Then we had a group which had IG-mediated allergy along with the which they represented or had atopic dermatitis. And the third group were the non-IG-mediated allergy groups. And what we did is we collected blood samples and stool samples from these subjects. The blood samples were then processed to collect plasma and PBMCs from them. And these PBMCs were preserved, or they were cryopreserved, and once all the collection was completed, they were revived. And then they were stimulated using cow milk protein, which was commercially available. And this cow milk protein causes stimulation of the PBMC or the CD4 T cells to differentiate into antigen-specific T-cons and Tregs. So how do you identify a T-con and Treg? Based on the expression of specific markers. The CD1, these are surface markers. The CD154 marker is expressed on the surface of T-cons, which are antigen-specific T-cons basically. And Tregs will have a marker called CD137, which are expressed on their surface. So if you can identify using antibodies, these specific markers using flow cytometry, and then those cells can be sorted using a flow cytometer. So this is just a depiction of how you will see. So these are the total cells, but these would be positive for CD154, the other one positive for CD137. So they can be just sorted out using a sorter, and then we performed RNA sequencing on these cells and try to identify the gene expression pattern. I'll talk about it in the coming slides. And from the plasma samples, we looked at the total cow milk and cow milk specific IG levels as well. Now, why we collected the stool samples? The stool samples were collected to identify the gut microbial composition. So we isolated the DNA from the gut microbiome and performed 16S RNA sequencing, from which we were able to identify the microbial composition. So we had 83 subjects recruited in total, and these were the numbers from each category. So as I said, the factors that influence the allergy, the clinical characteristics, we collected all these information from the parents and the medical records, like the allergy symptoms, like for example, the respiratory symptoms, mucocutaneous symptoms, etc. are generally shown by IG-mediated allergies, whereas in the non-IG-mediated allergies, they might probably show blood in the stool. So these kind of symptoms were recorded, and also the familial history of allergy was recorded. And we saw that the familial history were playing a role in both IG and non-IG mediated allergies. So it was seen in both cases. And we saw that there was a tendency of there was a tendency of multiple food allergies in IG mediated allergy groups as opposed to non-IG mediated allergies. Now, so the cow milk allergens could be different types of proteins within the cow milk, which could be caseins or whey proteins. The whey proteins again are of different types, lactoalbumin, lactoglobulin, lactoferrin, etc. So what we did is, because we have classified them into IG and the non-IG group based on the clinical records, now we wanted to ensure that these groups are actually IG and non-IG, for which we looked at the plasma levels of total IgE and common specific IgE, where we see that the levels of total IgE, common specific IgE were all high in these two groups. These are the IgE groups. This is without atopic dermatitis and this is with atopic dermatitis. So these two groups had high levels of IgE, whereas the non-IgE group had low levels, and it was comparable to that of the control group, which validated that the study groups were actually IG and non-IG groups. And so this is how the profile of CD4 T cells look after stimulation. So before stimulation, you can see that there is no expression of CD154 or CD139, it is very low. But after stimulation for 6 hours, you can see that there is an enhancement in these markers in these. So these are the antigen-specific T-cons and Tregs. So they were sorted out, and again we validated these sorted populations to using specific markers that are meant for Tregs and T-cons. So they are, this is more of scientific thing, but yeah, I'm just telling. So they are like expressing FOXP3, Helios and all. So these, the blue and the red, they are showing the two different populations. So the Tregs were actually Tregs due to the expression of FOXP3, Helios and CD25 markers, and the T-cons were actual T-cons. And the gene expression patterns also segregated them very well. Now, what we did, we compared the percentage or the frequencies of the Treg and the T-cons in the allergy groups. So when you compare, so the Tregs are the blue ones and the T-cons are the red ones. The control group shows there is no significant difference, it says non-significant difference. Whereas in the allergy groups, we can see that there is a increased proportion of the T-cons. As you can see here, there is increased proportion of T-cons in the allergy groups. So now we also looked at within the subject groups, what is the percentage in each case that the CD4, 154 and 137, what is the percentage happening within each subject. So this shows that in the control, there was only 15% of increase in the T-cons, but in the allergy group, we were seeing 89, 92 and even 100%. So when we calculated the ratio of T-con to Treg there, we found that there is significant upregulation of T-cons in all the IgE and the non-IgE groups. So this was, as I told, shown in IgE group, but not in the non-IgE group. So this was the first observation that we were showing. And we were able to conclude that the antigen-specific inflammatory CD4 T cells is dominating in IgE and non-IgE groups. Now, we wanted to identify, as I said, the T-cons could be of multiple types. It could be different types, subsets of T-cons. It could be Th1, Th2, etc. So we wanted to see what is happening within the T-con subset, what type of Th subsets are being highly represented, for which we calculated those, where we see that in the Ig-mediated group, there was upregulation of Th1, Th2, Th9, and Th17. Whereas in the non-IG group, we found an increase only for the Th17. So we also looked at the Th-like Tregs. These are some Tregs which tend to behave like T-cons. So they have a tendency to behave like inflammatory T cells. So they were also quantified, where we saw that in the IgE groups, there was increase in the Th2, Th9, and Th17 and Th22, but this was not seen in the non-IgE group. So this was a major difference in the cellular subset level. And we calculated the ratios of these subsets, which again show that there is upregulation of the Th subsets in the allergy, both Ig and the non-Ig groups. Now, so this was the conclusion that the CD4 Th cell subsets were upregulated in the IgE and the non-IgE groups. Now, as I told, we went ahead for the gene expression patterns, where we saw that there is differential gene expression pattern, not going into very detail of these aspects. But then I want to show that as we saw in the cellular levels, we saw that in the IgE and the non-IgE group, there were differences. In the IgE group, we see that there is upregulation of Th2, Th9, Th17, Th22, etc. in both ALL and AD, which are the IgE group. But this was not very evident in the non-IG group. In the non-IG group, we saw only Th17 or Th22 subset being upregulated. So there were differential gene expression patterns, although The T-con subsets were high in the non-IgE groups, which were comparable to that of the IgE groups. The underlying gene expression patterns were different. Also, when we calculated the gene expression patterns of the Tregs in both IgE and the non-IgE groups, these Tregs were found to be defective. They were not behaving as good as the ones in the control group because the gene expressions were much lower. That is what is shown in the lower panel. And these are the defining genes which directs the segregation of the T-cons and the Tregs. It is more into scientific. So the take-home message here is we looked at the transcription factors and the cytokine expression of the IgE and the non-IgE groups. So here we see that there is differential expression, like the second and the third are the IgE groups and the last one is the non-IgE group. The gene expressions are different, although the T-con subsets are high in both cases. The gene expressions within them are different. So in the Tregs, we see that in the ENP group, there is higher expression of these set of genes, which is low in the IgE groups. Similarly, if you look at the T-cons, again, you will see a different gene expression patterns, which are high in the non-IgE as opposed to the IgE and the IgE groups. Similarly, we looked at the cytokine levels. Cytokine levels, again, there are specific cytokines which are associated with the Th2, Th9 pathway. So those were high in the IgE groups as opposed to the non-IgE group. Now, in the non-IgE group, we found specific set of cytokines which were first identified, and these set of cytokines, the IL-1A, IL-1B, LTA, etc., were found to be upregulated in the non-IgE group. So this was again a novel observation that we identified, and this shows how the gene expression patterns are different in IgE and the non-IgE groups. And again, now coming to the microbiome aspect. So as I said, we collected the stool samples and looked at the microbiome profile. We calculated the microbial diversity, where we found that in the allergy group, there was microbial dysbiosis. And here in particular, we see that some of these microbes, that is Ruminococcus, Dilista, Roseberia, these are the gut microbiome, which are important for generating a Treg type of response. We saw that these microbes were low in all three allergy groups as compared to the control group. This was a very important observation because these microbes actually promote tolerance in the individual. So these microbes were going down in the allergy conditions. And when we calculated the dysbiosis score, we found that there is dysbiosis associated with both IgE and the non-IgE groups. And we then try to identify what kind of clusters are being, microbes are being enriched in each case. So these were the clusters that we identified. And then we looked at what's happening in each of these cases. In the control, what's happening, in the ALL, what's happening. So these, you can see C1, C2, C3, these are different clusters of microbes. For example, let's say about these Ruminococcus Roseberia cluster, you can see this cluster is high in the control group, whereas you can see it is low in the ALL, AD, and the ENP group, which means that it is talking about the same Roseberia, Ruminococcus, etc., which I said is promoting Tregs, is going down in the allergy groups. Now, there are kind of microbes which are called the butyrate producers. These are, butyrate is a short chain fatty acid, which again promotes development of Tregs. Now, the microbes were classified into butyrate and non-butyrate producers. We looked at the expression of these butyrate producers, which showed that, so in the control group, you can see high expression of butyrate producers, whereas it is going down in the ALL, AD, and the ENP group. Based on the scoring. So the red actually says high and the blue says low. So we see that it is going down in the allergy groups. So we also looked at the non-butyrate producers, which showed similar degrees, but also there were upregulation of some of these butyrate producers like Bellionella, etc., being upregulated in the non-IgE group. So we found that there is a difference in the gut microbiome composition in the allergy groups in general, as opposed to the control group, and there were differences within IgE groups and the non-IgE groups. So we know which are the microbes which are actually present in each of the allergy groups. And then we looked at a network. We developed a network that was involving the T cells and the microbiome, and we found what are the associations between the microbes and the TH subsets. It's complicated. So the green line says positive correlation, the red line says negative correlation, and it shows the direction of what you call association. So you can see what is the scoring patterns. So I'm not going into very detail of that, but then you can see there are more associations in the control group as opposed to the 3 allergy groups. This indicates that there is a diverse microbial pattern in the control, whereas in the allergy groups, there is microbial dysbiosis. And to conclude, so as I told in the beginning, when there is an antigen being ingested, this antigen is presented by an antigen presenting cell to a naive CD4 T cell. This causes the naive CD4 T cell to differentiate into antigen specific T cons and Tregs. So in case of tolerance, there is increased antigen specific Tregs and decreased antigen specific T cons. But in allergy, there is decreased antigen specific Treg and increased antigen specific T cons. The ratio is high. Now, within the T cons, in the IgE group, we see an upregulation of Th2 and Th9 subset, whereas in the non-IgE group, we see an upregulation particularly of the Th17 group and a new class of named CD4 T cell. Also, in the IgE group, we saw that there was upregulation of Th2 like, Th9 like, and Th17 like Treg subsets being upregulated. So these are Tregs which are behaving like T-cons in the IgE group. And we also identified that there was a decrease in the butyrate producers in both the cases and an increase in a particular non-butyrate producer, namely Bellionella and Akkermansia, being upregulated in the non-IgE group. So this was a cumulative study which involved CD4 T cell immune response and identifying the association of the gut microbiome and how they are modulating each other. So this is where I work. This is my hospital, and Dr. Nicholas is the head of our lab. He's a PI, and those are my lab mates. And this was a collaborative work which involved multiple labs, clinicians, and yeah, the core facility and everything. Thank you so much. I would like to take some questions.
Any questions?
I'm always the clinician in the group. How are we going to use this information? Because we know none of the probiotics that are available on the market, not any of these.
Yeah, but Akkermansia is currently being used for IBD, I guess, for other kind of inflammatory diseases, but not in case of allergy. So in terms of probiotics, identification of these microbes actually would help generation of new kind of probiotics that can be given to the child. And also right now I have another project which I'm running where I'm trying to identify a clinical diagnostic method, because in IG mediated allergy, you have the skin prick test to identify, yes, this child has allergy, but for the non-IG, nothing. It's like they do the oral, yes, avoidance test for maybe 4 weeks or like that, and then the child has to bear with everything that is happening in between that. It is a trauma for the mothers and everybody. So like we are trying to develop a test on the basis of the results that we have. The paper is actually in preprint. It has been published and is under review in a journal. So I hope to have it soon out.
Because in my grandchildren, the older brother is fine with milk, the younger sister isn't. So she takes his food.
Oh, yeah.
And
Yeah, exactly.
and
Yeah. Yeah. That's true.
Are there certain foods or something you can eat to get these types of probiotics?
So like there are certain kind of so as I said, the butyrate is a short chain fatty acid which is being produced by particular microbes like ruminococcus, rosewaria, etc. So there are I mean, you have to go back to the literature to identify what kind of foods do promote this thing. So the gut, basically the allergy is directly proportional to the gut, the diverse gut microbiome. So the worst your microbiome is, that can cause more tendency to develop allergy. So like for example, there is in Western countries, actually you say there is more development of allergies as compared to the Asian countries. In Asian countries, the children, because there is something called as a hygiene hypothesis. The more hygienic environment the child is being exposed to, they are not being exposed to multiple microbes in the early life. This causes their I mean, they don't develop the tolerance in their early age. So this can lead to the development of a tendency to develop allergy at a later stage. So those factors, apart from the genetic factors, the environmental factors, the dietary factors, all these play a very important role in the tendency or the predisposition to develop allergy. Yeah. All right. Thank you so much. Thank you for your attention. Can I just
So let's see. Thank you so much. You know, with this story. I think it we need your business and the next aspect is the communications of health and is for the general national, international, and challenges the global. The topic is in COVID maternal care. Is financial health and well-being. Please join me in welcome Dr. Professor King. Let's follow the regular please. Let's with the kids.
Good morning, everyone. I know it's almost like a tea time, so I'll be very fast. My name is Dr. Monica Perez-Oike, and my topic is enhancing maternal care and showing that it has a direct positive impact on perinatal care and their overall well-being. So just a bit about me. So I'm a graduate of Trinity College. I have 11 years experience as a medical doctor. I'm also working as a general practitioner for the last 5 years. I have a diploma in women's health, obstetrics and gynecology, dermatology, all the things that are very common in general practice. So I've developed a special interest in that, and also in women's health. And I suppose in the age of social media, I also have a keen interest in it, where I use my platform to do health education videos, just especially during the pandemic when it was very, very important. So why does the mother and child connection matter? There are 3 known undisputed facts. We know that the maternal physiology and exposures does shape the fetal development. We also know that chronic diseases in the mother raise the risk of miscarriage, preterm birth, and also has a long-term child health issues. And then there's been a lot of mention about mental health, and we know the maternal mental health actually influences the attachment and early child development trajectory. So when it comes to pediatric health and perinatal health, I think there should be a continuum of care, because it actually starts before the child is formed, before conception. So it's preconception, the actual pregnancy, and also postpartum. So, you know, in preconception, there should be nutrition review, medication review, and also chronic diseases optimization. And then during the antenatal care, there should be screening, disease control, and fetus surveillance. And then also postnatal care also does matter, because maternal recovery, the mental health, and also, like Dr. Linda said, that the developmental follow-up is very, very important as well. And I know, like in so many countries, and the way I think somebody mentioned that there's a mismatch in terms of our policies, and even like vaccines, where in some parts of the world there are certain policies and then in other parts it's different. But I think generally, when it comes to maternal health and also perinatal health, there should be a basis that's common worldwide. And I hope that with these few things I've highlighted, we'll take this back to our practices and implement them. So one of the things I'm really, really passionate about, and that's because in my care as a general practitioner, I see a lot of young ladies that are actually folic acid deficient. And this folic acid and perinatal health is actually, folic acid is one of the foundations of perinatal health, because the general advice is that folic acid is for a mother should be taken at least 12 weeks before she actually gets pregnant. And then also during pregnancy, because this can prevent neurotube defects. So things like spina bifida and encephaly, where the brain doesn't develop, and unfortunately could lead to miscarriage and also death as well. And the standard recommendation is that for low risk women, that they should be on 0.4 milligrams daily. And then for high risk, and that would be people that have already had children with neurotube defects and also a history of malabsorption, they require a higher dose. In my country, in Ireland, it's 5 milligrams we do prescribe when we have any person that is deficient. There are a few studies, and folic acid actually, I feel, is one of the vitamins that's been widely studied. And this paper there shows that if you have taking folic acid, it actually prevents occurrence of neurotube defects. And then the other paper there, oh, there we go. So the second paper there actually shows that there could be a 70% reduction in neurotube defects in mothers that have actually had a history of kids with neurotube disorders by just giving them folic acid. So it's so important that we implement that. Now, we know the barriers to implementation is, like I said, delayed presentation to care. A lot of pregnancies are not planned, but a lot of people are happy when they do get pregnant, but there should be the preconception care. And that is something that I think is lacking. And there's so many barriers to that. Obviously, cost is the big issue, and also the lack of planning when getting pregnant sometimes. And then one of the things is that there's actually some countries that have national fortification policies. And this is where certain foods like flour and wheat are fortified with folic acid. So I went on a rabbit hole in that. I think there was a study done about 30 years ago, and it proved that folic acid is very important. But till date, less than 100 countries actually have national fortification policies. And some countries, and I was very shocked that actually in Europe, I didn't find any country that had a national fortification policy. And then there was a study that was done in 2019 that looked at countries. So about 56 countries met the criteria for the national fortification policies. And it showed that over 65,000 cases of neurotube defects were prevented just by the national fortification policies. So I think if we take anything back from this talk, is that folic acid supplementation is so important. Another thing I looked into was the thyroid disease and perinatal health. Thyroid disease is a disease that the thyroid gland, as we know, is the butterfly gland. There is basically, I tell my patients, it's basically like the battery in your body because it regulates so many things. And unfortunately, thyroid disorder is quite common in women. But there's a good link with thyroid disease and perinatal health. And we know when people are pregnant, their need for the need for thyroxine is actually increased. But overt hypothyroidism could lead to miscarriage, it could lead to preterm birth, and it could also lead to adverse fetal development. And there was a study I looked into, and it showed that insufficient thyroid function in the mother could potentially have an association with intellectual disability in their offspring. And unfortunately, even when supplementation does happen after pregnancy, the effect of that disability is already there. And this is where the preconception care is very important. Looking at that, the question is, how do we screen for this? Should there be a national screening for all women before they get pregnant, or should it be just high risk? And looking at the American Thyroid Association guidelines, they did suggest that it should be high risk people that should be screened. So that's people that do have a history of thyroid disease, symptoms that are suggestive of thyroid dysfunction, people that have autoimmune disorders, and if there's a family history of thyroid disease, and if they've had previous neck irradiation or thyroid surgery. I know that's the thing, but just in care, this is where the preconception care is so important, because if we now preconception care, we screen for folic acid, we also screen for thyroid disorder. It's very simple. It's a simple blood test. That in itself, we can catch that before the mother gets pregnant. Another thing that also can have an effect on the perinatal health and the mother is hypertension, maternal hypertension. Some women do have hypertension before they even get pregnant. Then there is gestational hypertension, and then there's preeclampsia. And all this can pose a risk to the mother and also the fetus as well. And the future risk could include like growth restriction, and therefore leading to a spontaneous preterm birth, and unfortunately stillbirth, which nobody wants. And then for the maternal health as well, hypertension can lead to organ dysfunction, eclampsia, and lung cardiovascular diseases. Hypertension and your blood pressure is something that can be easily tested and checked. And even now, you can go to the pharmacy, you could get it checked, you could buy a machine, and you could actually get that checked. Well, if we have a show of hands there, how many of you have checked your blood pressure in the last 3 months? Hands up. See, less than 5% of the people in this room have checked their blood pressure. And it's so important. It's a very easy thing that we can check. And this is where that preconception care should be there as well. So how can we reduce the chances of these complications? We need to identify high-risk women early. And we know, thankfully, contrary to, I don't know if anyone saw Trump's speech about paracetamol, and he went on a waffle about so many things. And he actually mentioned that, that even aspirin shouldn't be taken in pregnancy. Aspirin can be given in pregnancy, it's widely prescribed in pregnancy, and it could help with the complications associated with hypertension. So I suppose misinformation is also something we should tackle. And then also once we notice that there is maternal hypertension or gestational hypertension, there should be fetal surveillance to check the growth of the child, and also planning. And then postpartum care is extremely important. Time and time again, I've had patients that do develop gestational hypertension or unfortunately preeclampsia, and they seem to have symptoms even long after delivery, and it goes beyond the 6 weeks, the 12 weeks. So that is also important. Mental health was also something that we've talked about a lot and yesterday and today, and the effect of maternal mental health actually has an effect also on perinatal health. But what are the things that do affect, causes the mom? So what are the social determinants of mental health in the mother? And this is something that if we are aware of the social determinants, then we can actually find at-risk women and subsequently improve their health. So things like low socioeconomic status, poor education, lack of employment, social support. It's widely said that it takes a village to raise a child, and unfortunately, with poor social supports, that could actually affect the mental health of the mother. Housing is a big thing. There's a worldwide housing crisis. If the mom doesn't have a place to stay, obviously, even without being pregnant, that can have an impact on anyone, then coupled with pregnancy. So that is something that we should be aware of. And then, unfortunately, intimate partner violence is something we know that risks women. One of them is their partners. That in itself has a severe effect on their mental health. And then access to healthcare. I know Dr. Linda was saying that the closest tertiary hospital is about 6 hours away. In so many communities, it's very hard to even get that. And that is why that in itself can have an effect on the maternal mental health. And then with that having an effect on the mental health, it could actually have an effect on the child. It could cause it could cause delayed cognitive development. It could cause attention deficit disorder, and then it could actually affect the attachment pattern of the child as well. And actually, chronic maternal stress and poor mental health can actually predispose the child to the same disorders as the mother. Diabetes is something that also does have an effect on the mother and could affect the child as well. And in the child, it could, so that maternal diabetes can pose a risk to the child and lead to some congenital anomalies. It could cause macrosomia, where the child is quite big, and unfortunately, birth can become difficult and lead to like shoulder dystocia. And then preterm birth could happen. And then even after the birth, the child could have the neonatal hypoglycemia and also be at risk of metabolic condition. And then with the mom as well, having gestational diabetes could have a, she would then be at risk of having a cesarean section, and then she could actually subsequently then develop type 2 diabetes as well. And this paper just kind of looked into the effect on the maternal diabetes on the child, and it showed that some children that did have that had mothers with diabetes could then predispose them to obesity as well. And I feel like I'm saying the same thing, but preconception care and looking after the mother is so important, because that I've shown now that that has a direct impact on the child. So practical recommendations I have for us as clinicians is that we should actually implement an integrated care model when it comes to maternal care. And it's not just obstetrics. And I think Dr. Linda actually pointed that. So looking after everything. So there should be endocrine involved, psychiatric care and social care as well, and also specialists. I know it's very hard, especially in some countries where you literally have to pay for everything, or where there's even lack of access. But if us as clinicians can actually work together, and we can show that that in itself can helping the mother, would definitely, most definitely help the child. We also need to encourage patients to have preconception care so that we can check their folic acid, check their thyroid function. In my country, in Ireland, thankfully, maternal care is free. So once you're pregnant, your visit to the doctor, your visit to the hospital is free. So that in itself, it's good. But that preconception care isn't free. And in an ideal world, if I was like the health minister, I think I would say that each woman should have at least one free health check to the doctor, especially if they're planning to get pregnant. And then we should include things like that. And then we should also know that postpartum care, postpartum follow-up is very important. And lastly, I want to also highlight the importance of community engagement and education, because the world is now becoming multicultural. Therefore, we need to get into the communities and educate members of the public as well. And this is where the pharmacists, the dietitians, the psychologists can help with that, because they can, once we empower them through education, like what I do on social media, I actually tend to then reach people that would not automatically go to the doctors with the short videos that I can do. And then loads of organizations, and I really cherish them, because there's so many awareness campaigns. Like this month's Breast Cancer Awareness Month, is Menopause Month, and there's so many awareness campaigns, and that is so important in looking after maternal health. And then we need to actually have that joint decision making when it comes to the mother and the child. Like you said we need to get down to their level and explain to them, and also understand why they might have barriers to these services. So all in all, I hope I've been able to prove that maternal health optimization before, during, and after pregnancy directly benefits perinatal outcomes and the child well-being. Thank you. Yes.
And how much importance it gives to natural childbirth in Egypt? And we have the importance of screening for the babies.
So the natural childbirth. Oh, it's so important. We actually have something, midwife-led maternal care. So we have, and then so when people come to the doctors for their first pregnancy, especially if they have no contraindication or chronic health conditions, we can encourage them to have the midwife-led care. There's obstetrician care as well. So it's very important. There are doulas as well. So we recognize all forms of childbirth. I know in terms of the doulas, there's an issue with insurance and things like that. But I think the world in general, they are moving away from, they're going close back to our roots in terms of having things done naturally. So we try to encourage that as well, as long as it's safe. So that's very important. Sorry, what was the second question? Oh, neonatal screening. So neonatal screening is actually good and it's done in the community. Unfortunately, me as a GP, I don't necessarily have an input to that. I know after childbirth, there is the 2 weeks check when the child comes to the doctor and to the GP, the family physician. And then there's a 6 week check as well, where we see the mother and the child. But after that, then it's a public health nurse that does that. And I only then see the child if there's an issue with their health or their growth or things like that. So, but it is there. It is kind of integrated. I must say we do have a really good healthcare system in Ireland. It's kind of integrated, but I sometimes feel me as a physician, there's a loss where I don't get to see the child grow as much as I would, especially since I was there through or legs they have an issue. Okay.
It's usually on day 2, we take the protein test. We all
Oh yeah. Oh yeah, the heel prick test we do. Yeah.
Usually second day. And so full screening.
Oh yes, is that type of screening you're talking about? I thought you meant like the checks. Okay. Oh, thanks for that. Yeah. Yeah.
Hi, this is your time you to have the coffee. So maybe we'll catch up in 5 minutes inside. We can see temperature. Yeah.
Yes, sure. Okay, can I just take a picture of that? Thank you. How can I go out? Um, Excuse me, brother. I'm sorry, do you know what is the file of the presentations? Oh, I will this one. Okay. Hmm? No, no, I will just take pictures, then I'll leave it. Yes. Good idea.
Yeah, as long as it's.
Yes, just you can do the same if you want. Zero. Yes. يبدأ مع شكل متشيك ya. عشان أقول يدري في. Bir şekilde. Aslında böyle yaxşı. Bir bak. Evet. Yani falan çek. Ele çekti buradan. Oradan çek. Böyle. Ben de çektim. Yo yo buradan kızım. Все. Oh, you got this. I have a lot. For your hemen yazmamışım. Sağ ol, çok sağ ol, çok sağ ol. Benim de bunu açar. Evet. Başlayayım. Gidi sen. Bir tavuk. No,
Hi, welcome back, everyone. Let's start our next session because we are running short of time. So, our next speaker is Dr. Kamila Ahmedova from Azerbaijan, a pediatrician and neonatologist. Her talk is entitled Conditions Found in Newborns Born to Diabetic Mothers France, a real world model for early intervention. Welcome, doctor.
Thank you. Hello, everyone. I hope you enjoyed the break. Firstly, I want to say it's a great honor to be here among professionals from all over the world. Before I begin my presentation, I would like to start by briefly introducing my homeland, land of fire, Azerbaijan. Thank you. Allow me to share a short 30-second video showcasing some of our country's most beautiful and remarkable landmarks.
Thank you. Dreams of Azerbaijan, a country rich in history, culture, and hospitality. Let me introduce myself. I am Dr. Jamila Ahmedova, a pediatrician and neonatologist working at Yeni Klinika in Baku. Which is largest clinic medical center and most advanced medical center in Azerbaijan and Caucasus region. And today I honored to speak about a topic that we frequently encounter in our daily practice, conditions found in newborns to born diabetic mothers. During the next 20 minutes, I'll briefly walk you through the background and pathophysiology of diabetes pregnancy, highlight the most common neonatal conditions we see in these infants, discuss clinical management and prevention strategies, and finally, findings from a few recent research studies. Global burden, it seems we, in our practice, diabetes during pregnancy is no longer higher. According to the World Health Organization, approximately 1 in every 6 pregnancies worldwide is affected by some form of diabetes. The prevalence of gestational diabetes mellitus can reach up to 20% in certain regions. As maternal age and obesity rates rise, we are seeing a more neonates born to diabetic mothers, meaning more infants at risk for both metabolic and development complications. Let's start with the basic mechanism. Maternal hyperglycemia leads to the transfer of excess glucose across the placenta. However, insulin cannot cross the placenta, so the fetal pancreas reacts by producing a large amount of insulin. And as a result, in fetal in hyperinsulinemia, which acts as a potent growth hormone, promoting fat deposition and tissue overgrowth, while paradoxically delaying functional maturity in some organs, practically the lungs and the myocardium. The combination of high fetal insulin and fluctuation glucose levels can cause multiple downstream effects. Firstly, it reduces surfactant production, which increase the risk of respiratory distress syndrome, even in term babies. Secondly, oxidative stress and inflammation contribute and endothelial damage. Perhaps most interestingly, new studies suggest that these enterouterine chains cause epigenetic modifications, essentially programming the child metabolism for increased risk of obesity and diabetes later in life. Where we see classification of diabetes in pregnancy, we know there are 2 types of gestational diabetes mothers. There are pre-gestational diabetes mothers and gestational. And pre-gestational diabetes mothers have 2 types of type 1 and type 2 existing before pregnancy. And it causes certain congenital anomalies and gestational diabetes diagnosed during pregnancy, which cause metabolic complications. Major neonatal complication. There are several complications which we see. Most of them hyperglycemia, respiratory distress syndrome, cardiomyopathy, congenital anomalies, and we also often encounter polycythemia, hyperbilirubinemia, hyperglycemia, macrosomia, which can lead birth trauma. Neonatal hyperglycemia. Hyperglycemia is the most common and well-recognized complication. It is typically defined as blood glucose below 40 milligram per deciliter, and most causes occur within the first 6 to 12 hours after birth. The mechanism is straightforward. Maternal hyperglycemia stimulates fetal insulin production, and when the umbilical cord is cut, glucose supply suddenly stops, but insulin remains elevated, causing the glucose to drop rapidly. This is why early monitoring and immediate feeding and critical in all infants of diabetes mothers. And here I want to show you mechanism in detail. So how exactly does hyperglycemia develop in these infants? Maternal glucose crosses the placenta freely, but insulin does not. As a result, the fetal pancreas reacts to maternal hyperglycemia by producing more insulin. When the baby is born, that continuous glucose supply suddenly stops, yet the insulin remains elevated, leading to sharp fall in blood glucose. This imbalance is what makes hyperglycemia such a frequent and early complications. Here we see symptoms and management. Symptoms, there are several symptoms in newborns: jitteriness, lethargy, poor feeding, apnea, seizures. And what we do in management, early breastfeeding or expressed milk. If symptoms we give intravenous glucose 10%, continuous glucose monitoring for 48 hours. And what we do in prevention, actually maternal glycemic control, early feeding within 30 minutes, and continuing glucose monitoring. Respiratory distress syndrome. Now, respiratory distress syndrome is another classical classification. It's one of the most seems complications in newborns. Even in term infants, we often observe immature lungs due to delayed surfactant synthesis. High fetal insulin levels inhibit surfactant production, which increases the risk of respiratory distress syndrome. These babies may require early CPAP or surfactant therapy, and we must always maintain normotherapy and gentle ventilation. Even we see cardiomyopathy, seen up to 30% of infants of diabetic mothers, caused by myocardial glycogen deposition. Usually involves interventricular septum, may cause LV outflow obstruction. This condition is caused by glycogen accumulation in the myocardial cells. It may result in transit outflow obstruction and can mimic congenital heart disease. Fortunately, most causes result within a few weeks. However, echocardiography or screening is highly recommended, especially in the infants show tachycardia or signs of heart failure. And then we see several congenital anomalies. When diabetes exists before pregnancy, what we call prenuptial diabetes, the risk of congenital malformations increases significantly. The most common are cardiac transposition of great arteries and coarctation of aorta. The good news is that this risk can be largely prevented through optimal maternal glucose and control before conception. Thalassemia and hyperbilirubinemia, chronic intermittent hypoxia, up to erythropoietins, and hematocrit often under 65%, leads of hyperviscosity, thrombosis, and jaundice. Well, what we do in management, monitor hematocrit and bilirubin control, partial exchange transfusion if symptoms have. Hypoglycemia and hypomagnesemia, electrolyte disturbances and another common findings. Around 20% of infants of diabetic mothers develop hypoglycemia and hypomagnesemia. The reason is a delayed parathyroid response and magnesium deficiency secondary to maternal loss. Clinically, this may present with tremor, irritability, or seizures. Treatment involves IV calcium gluconate 10% and magnesium supplement. Macrosomia and birth trauma, it's another complications. One of the most visible consequences is macrosomia, excessive fetal growth. These babies often weigh more than 4 kilograms, have broad shoulders and a round face, something described as a cheboric appearance. While this may seem reassuring, it actually increases the risk of shoulder dystocia, clavicular fracture, and brachial plexus injury. Neonatal management overview. Immediate management after delivery focuses on prevention and stabilization. We should check the first blood glucose within 30 minutes after birth, maintain the infant's temperature, and encourage early feeding. Continuous cardiac, respiratory, and glucose monitoring during the first 24-48 minutes hours is essential to detect complications early. And here we see monitoring and follow-up. Beyond the immediate period, ongoing monitoring remains important. We typically risk check glucose every 3 hours, evaluate calcium and magnesium on day 2, and perform echocardiography if there's murmur or tachycardia. Long-term follow-up should assess growth, neurodevelopment, and glucose tolerance. Maternal glucose control and outcomes. Type maternal glucose control, neonatal complications. Hemoglobin A1C under 6.5% associated with better outcomes. Postnatal term approach critical with obstetrician and neonatologists. We see here a summary of immediate risks, in persons. Long-term outcomes, the story doesn't and it's discharge. Infants born to the diabetic mothers face long-term risks, even if their immediate neonatal course is stable. And there we see a childhood obesity, insulin resistant, and increased type 2 diabetic risk later in life. Neurodevelopment delays, cardiovascular risk, vascular risk later in life, and other. Prevention and care strategies before birth and after birth. What we do before birth, from mothers, strict glycemic control, maternal hemoglobin A1C under 6.5%, fetal growth monitoring. After birth, we early feeding and glucose checks in newborns, continuous follow-up of growth and development. Multidisciplinary approach, coordination between obstetricians, neonatologists, and endocrinologists, family education on glucose monitoring and nutrition screening for complication during infancy. At birth, we check glucose within 30 minutes after birth. If glucose under 40 milligram deciliter, we give intravenous glucose 10%, 6-8 milligram kilogram minute. We repeat checks every 3 hours until stable. What we monitoring, calcium, magnesium, and bilirubin, and follow up echocardiography before discharge. It's one experience in our clinic, Uniclinica. This newborn was born with kilogram 4.9, and in our neonatal department, we frequently encounter infants of diabetic mothers within varying degrees of metabolic instability. Early detection and team-based management have shown significantly better outcomes. And here we see maternal control and neonatal outcomes diagrams. Neonatal care key components, glucose and temperature monitoring, early feeding, nutrition, glucose and calcium monitoring, screening for cardiac and metabolic anomalies, family counseling, and information. Here we see I take here one research what perspective study in Romania from 88 diabetic mothers and 138 newborn controls. High incidence of respiratory distress syndrome in neonatal intensive care unit admissions, and cardiomyopathy. And other research is molecular research example with Azuma and her colleagues in 2024. They study term and late preterm infants of diabetic mothers, examine salivary gain, expression, and body composition. Their findings fat mass and expression of hunger regulation genes. Their feeding initiation delay in some infants, and in conclusion, they find that maternal diabetes altered neonatal body composition and gain expression, suggesting epigenetic influence on long-term metabolic risk. And here I want to give a key message. Infant diabetic mothers remain at risk even with good maternal glucose control. Hypoglycemia and respiratory distress syndrome are the most frequent complications. Long-term follow-up is crucial. New research shows genetic and metabolic reprogramming in these infants, fetal hyperinsulinemia. Early prevention has outcomes. Teamwork, of course, obstetrician, neonatologists, and endocrinologists. And in conclusion, I want to show our clinic. What I say in early, it's largest is the largest and most advanced medical center in Azerbaijan and Caucasus region. And our clinical experience at Uniclinic aligns with global evidence. And at finally, I want to say, based on my topic, good glucose control is the best newborn's protection. Thank you for attention. If there are no questions, I'd like to thank you. Let's take back to visit.
Yeah. Sorry.
I would like to know how I see Rima Al-Jabbar, an associate consultant in pediatric emergency. Her presentation is titled Pediatric Emergency Essentials. Please join me in welcoming Dr. Fatima Al-Jabbar.
So, hello everyone. Thank you for your attendance. I'm Dr. Fatima Al-Jabbar, Pediatric Emergency Associated Consultant. Actually, it took me quite some time to reach out to choose this topic. as I have noticed that we are coming from different background, different specialty, and different experience. And by the way, how many of you receiving consultation not related to your subspecialty? And you are receiving all. Okay, so for me, I received some consultation not related to pediatric emergency. So I thought we will have some here. I hope by the end of this presentation, you can answer the consultation that related to pediatric emergency. So it's going to be short cases, and then we will have a short discussion about it. So the first one, we had a 3-year-old child who was playing with his older brother, who pushed him on the ground. The younger child fell down on his head, started crying, shouting immediately, and then he slept. Mom brought him to the emergency department and asking for a brain CT. So what do you think? Would you do a brain CT for this child? Yes, no. Who said yes? Who said no? Yes? Okay, who said yes? 1, 2, 3. And who said no? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so before deciding whether to say yes or no, we have to ask some questions. What's the age of this child? He is more than 2 years, so most likely we are reassured. We should ask the mother, is there any history of loss of his consciousness, any seizure, any abnormal movement, any change in his personality? He was acting normally, any vomiting, but actually we have to be careful with the number, not any vomiting. We will do a brain CT. It should be at least 3 or more. And one more question we have to ask about the type of the injury. Was it a high-speed accident? Was it fall from 3 meters or above? Then we can decide whether to do or whether not to do a brain CT. All right. So the next one. Okay. So we have 2 child. First came, both came with the same history. 4-year-old girl complains of runny nose, cough, sneezing, and then presented to you at the emergency department with abnormal movements affecting all her body, lasted for less than 1 minute. And mother told you it's actually happened yesterday. And since then, she is acting normally. And comparing to the second child, who is also a 4-year-old girl, complains the same thing, runny nose, cough, sneezing, presented to you with abnormal movement affecting her this is the right arm, and it lasts 15 minutes, repeated 3 times, and since yesterday. So, what do you think? Which one need to be investigated? Child 1 or child 2? Okay, who said 1? 1. Who said 2? Okay, so it's okay, so we need to investigate 1 or 2? 2. Or both of them? Because the investigation is sometimes it's hard for the child as well. Like putting him in CT is carcinogenic. With the CT, most probably will need anesthesia at this age. So a risk of anesthesia as well. Risk of admission, fear of needles. He will need EEG. So it's not easy to investigate both of them, and the child is not required. No, it was runny nose, with generalized abdominal movement. Can we go back? This one. You're right. Okay, so the first one is simple febrile seizure. The second one is complex febrile seizure. The difference between both simple febrile seizure, it's usually generalized less than 15 minutes. A child recover faster, and it's actually not recurrent within 24 hours. Comparing to the second one, which is more complex, affects only one part of the child, either upper limb or lower limb. It lasts more than 15 minutes. It can recur within 24 hours, and the child is not recover very quickly. The second child. All right. Okay. So here we have a 7-year-old child was playing and he found a bottle. He thought that it was they like to taste everything. They can detect. Okay, so he is a 7-year-old child. He was playing, he found a bottle. He thought it was a milk and he drank that bottle. Then he ran to his mom, of course, and the mom found it was Clorox. It's a common scenario in the emergency department. So the mother put her finger into his mouth to induce vomiting, so he get rid of all what he drank. So my question is, was her action right or wrong?
It's a risk of aspiration clause.
And you are right, absolutely. It's a high risk of aspiration, and there is some. At least we are agree that it is wrong. Exactly. No need to induce vomiting because yeah, because we don't know, or the mother doesn't know what he had drunk. This time it's a Clorox, maybe he had something else. If it is not causing burn while he ingestion, so it will cause pain while he's pain or burn, sorry, while he's throwing this material out. So please do not induce vomiting after this type of ingestion. Yeah, no need. Because if you don't know what he had, it could be acid, it could be alkaline. This stuff can cause burn. So the burn, if it is not severe while he was ingested, it will be more severe and more complicated while he's throwing this out. Okay, so what shall we do in this situation? Please do not induce vomiting, but we can instead wash his mouth. Some articles says that he can drink a small amount, very small, minimal amount of water or milk, and please seek medical advice immediately. And please take the material with you. It will help the physician in the emergency department, and it will help the toxicology as well. All right. So the next one is, you were in a restaurant. Suddenly you heard a child who was choked with a small toe. And the mother was panicking and crying, and she doesn't know what to do. How would you help? Hmm?
Oh,
5-6 years.
I forget the name of
Abdominal thrush, you mean? Before the abdominal thrush, we have to slap his back, exactly. But the most important message, exactly, you're right. 5 times slaps, then 5 times abdominal thrush, and we can do even chest thrush. But please do not. Cameron. My nose, Cameron. Okay. Okay, so my message here, please do not try to remove the object unless you can see it by your eyes, because what happened is that yes, exactly, they are trying to help by putting their fingers blindly, and unfortunately it goes more inside and deeper. Exactly. Okay, so I think this is the last one. You had 7-year-old child came to you, came with his mother, complains of loose motion 4 to 5 times. Yesterday it has no blood, no other complaint, no fever, no vomiting. Child looks well to you, and mother is asking for a medication to stop his diarrhea. Okay, would you give a medication to stop his diarrhea? Who said yes, who said no? No, no, no. Exactly. It is no. In pediatric, we don't go. Yeah, exactly. The cough, the diarrhea, they are a defense mechanism of our bodies to get rid of whatever infection he has. So he, please, please, please give the mother, ask the mother to give plenty of fluid, oral hydration, and give clear instruction when to visit the emergency department. She should visit the emergency department when the child decreases his oral intake, when he is lethargic, he is sleepy, he is not taking orally well, he has a dry mouth, he has dark urine, or even decrease in his urine output. And if it is continued more than 3 days, or if it is associated with the blood. And this is to take home message. I hope I was short and clear. Okay, so to take home message, not all head trauma need a brain CT or brain images. Simple febrile seizure is very common and doesn't need any intervention. Do not induce vomiting after causative ingestion. And lastly, do not remove a chalked foreign body unless you can see it clearly, and no need for antidiarrheal medication, but patient should receive plenty of a fluid and oral hydration solution. And thank you. This is my Instagram and my email to stay in touch. Do you have any questions? Welcome. Thank you.
Just one thing, sorry. Patient 3 meters height, one of the red flag of
Yes.
little bit risky. 3 meters is like this. Just imagine a different from that.
Yeah, it is one of the red flags. If it is a high distance, we will investigate the child.
Because the one country with 2 meters or 2.5, then you are not going to risk.
It depends on his situation, but not if each and every single fall from 1 meter. 1 meter is like that. Am I right?
Yeah.
Higher. Okay. I'm 1.5 meter. So if he falls from my height, it's not a clear indication for a brain CT.
Height of child, so double height of the infant. Below 2 meters. That's
no, below 2 years. It's a little bit a different guidelines. That's why I said if it is more than 2 years. If it is less than 2 years, you are absolutely right. Thank you.
Thank you.
My question, maybe this is not question, about the CT scan for patient who fall down. In your situation, I need because after fall down, you say patient was lethargic and asleep, yes?
No, I said he cried. After the crying, he slept. It doesn't mean he's lethargic. Each and every child he's fall down, he will cry and sleep immediately.
My patient, not two, 3 years, go down in kitchen after cry and no bone, nothing. Mother said, okay, nothing. All right, good. After 1 week, patient was very, not very, but was lethargic, won't sleep all time, and lost level hemoglobin.
Okay, so he's bleeding inside. Yeah. Hematoma. Yeah, the hematoma, which is not located in the skull, is one of the indication of a CT brain. But maybe he had this hematoma from the beginning. I think he must have this hematoma from the beginning. Or it was a small and getting bigger. Yeah, I think this is what happened. It's getting bigger. Yes, you are right. This is one of the indication to do a brain CT if there is hematoma not located in a frontal area. Yeah, you should do CT in this case, of course. Yes.
I guess we have
Just if you have any doubt about the child, admit him to case for 24 hours observation. Okay, so if you are not sure the child is sad, okay, what kind of sleep is he due to collection inside the brain? So I need 24-hour observations. So the best way is to admit that child for 24 hours.
Exactly.
If you have no bed upstairs, like say it's the work, you can keep them in the okay.
But I think this child came to them after 1 week, not directly after the trauma. Yeah. He didn't seek a medical advice. No. Yes. Yeah.
Please, our ask for just one last question, please, because we are so much, Dr. Fatima, you come down with.
Thank you, everyone. Thank you for your listening.
Next speaker is Dr. Adrian Ismail Akinola. That's major course specialized diploma in pediatric and faculty of pediatrics. Station is faculty of diagnostics and treatment hospitals. He wants to. Please welcome Dr. Adrian.
Good morning or afternoon. I think. Yes, my name Dr. Aytekin. I know this is a bit difficult to pronounce, so you can say Dr. Aya, no problem. I am from Azerbaijan, Department of Children Disease, Azerbaijan Medical University, assistant professor, and my practice in maternal child hospital in Baku. This is Pediatric Institute. This is clinical practice. Today, before I start my presentation, I want to say thank you for all organization group. This is summit, and for me, honor stay in front of all of you and present my presentation. Thank you for attention. Today we will discuss about what's new in diagnostic and treatment sepsis. Sorry, microphone. Yes. Hello? No. Microphone, I think, don't work. And this, please. Sorry. No. Don't work it, so I cannot change. No.
Oh. You're just using
And here?
the down arrow and the down arrow, the page down.
Please. Okay. Because I start my presentation, I want to say we know sepsis, this is very critical condition. This is life-threatening organ dysfunction for all age, and especially for newborn and especially for premature babies. Sepsis is never mild. It's always a severe acute condition. Cause sepsis, this is low body weight in infants, hypoxia during pregnancy and asphyxia during delivery, depression of organs functions, maternal perinatal development factors, rupture of membranes, full smelling, contaminate amniotic fluids, male sex, low social economic status. Disease prevalence, early neonatal sepsis, 0.5 to 8 per 1,000 children. Mortality rate, 1 to 5 per 1,000 children. Potential adverse condition. This is social, divided social, biological, and clinical. And so threshold for assessment and treatment. Yes. Okay. Neonatal sepsis divided to early neonatal sepsis and late neonatal sepsis. When we say about early neonatal sepsis, if septic conditions start after delivery during 4 days, first 4 days. If after 4 days, after 5-6 days start septic situation, septic condition, we say about later sepsis. Hospitalization immediately after birth, systemic infection, maternal urogenital infection, and bacteremia. Epidemiology sepsis, neonatal sepsis is responsible for approximately 20% of neonates disease death in the world. Annually, 1 to 5 per 1,000 children worldwide die from early neonatal sepsis. By World Health Organization, neonatal sepsis contributes to 1 million deaths annually, representing 10% of total under 5 childhood mortality. The incidence of sepsis among newborns within the first 30 days of life range from 1 to 8 per 1,000 live births. For preterm infant, the incidence is significantly high at approximately 1 in 250 babies. Extremely low body weight, 50%, 60% of all disease cause occur in neonates. Etiological factor. This is usually agent of neonatal sepsis. Group B, Streptococcus agalacti, E. coli, Escherichia coli, Enterococcus, Listeria monocytogenes, and also being notes, Campylobacter fetus. Usually more times this is for premature etiological factor sepsis. Early neonatal sepsis pathogenesis start placental inefficiency. This is intrauterine infection. Ascending road of infection, early sepsis due to infection of amniotic fluid, rupture of membranes infected with group streptococcus. Neonatal sepsis for diagnosis, this is diagnosis of intra-amniotic infection can be confirmed through microbiology culture of amniotic fluid, neonatal risk calculator, clinical monitoring, and laboratory evaluation. What's new on diagnostic sepsis? This is neonatal sepsis calculator. Neonatal sepsis calculator was created in 2017 and update in 2024. The method, this is called permanent group organization company. The method is intended to improve the selection of newborns with suspected early onset sepsis in order to optimize empirical antibacterial therapy. This is very important because last time start antibacterial therapy, don't wait. Start antibacterial therapy. So this is method very nice method. Diagnostic and start antibacterial therapy. Neonatal sepsis calculator uses the extended frequency of early sepsis, gestational age, maternal hyperthermia during pregnancy, premature rupture of membranes, group B streptococcus, and other microorganisms infected the mother during pregnancy. Neonatal sepsis calculator clinical monitoring. This includes clinical monitoring, laboratory evaluation, determines the type of ante and intranatal antibiotics to prevent the risk of neonatal sepsis. Neonatal sepsis calculator indicated promoted a reduction in antibiotic use, reduced repeat hospitalization in the intensive care unit, reduction in mortality. Recommendation of Neonatal Institute for Health and Care as NICE divided into isolated intrapartum fever, chorial and chorioamniotitis. All of them, this is the risk factor for early neonatal sepsis. Clinical practice guideline of American Academy of Pediatrics, AAP, divides infant from risk group more than 35 weeks and less than 35 weeks. Recommendation of NICE, they take all gestational groups are analyzed concurrently. So preterm birth before 37 weeks of gestation is considered a red flag indicator. Objective of the AAP and NICE guidelines accurate detection of infected newborns, reduces unnecessary antibiotics exposure in uninfected patient. What it is a red flag? Red flag used as indicator to determine which newborn require evaluation and treatment for sepsis. In newborn with a single red flag, initiation of antibiotic therapy is recommended. 2 or more non-red flag indicator in children with one risk factor or clinical indicator, clinical judgment should be used. If antibiotics therapy is not initiated in neonate, close monitoring at least 12 hours is recommended using an early warning scoring system. As a gold standard for confirming a diagnosis of neonatal sepsis, isolation of a microorganism from a sterile blood culture. Take 1 milliliter of blood to detect pathogens. The number of calculate neutrophils in the neutrophil index, C-reactive protein, interleukin, hemokin 8, interleukin 8, calcitonin, antigen of the surface of circulation cells, soluble ST14, ST64, HLA-DK, systemic biological markers. The gold standard, take sterile locus blood collected on the date of birth, after delivery, immediately. If this patient, and especially for patient, if risk groups, mother temperature, rupture membrane, and fluid, smell fluid, amniotic fluid, and other. Clinical signs of neonatal sepsis. Bacteremia detected in 1 milliliter of blood. In vitro testing of placenta blood. Colony forming unit milliliter for E. coli or group B streptococcus enough 0.25, 5 milliliters all sample. Recommendation. Take 2 blood culture, aerobic and anaerobic, recommended before starting antibiotic in older children. 1 aerobic blood culture medium enough in use in neonate. Why? Because most common bacterial infection in this population, neonate age, are caused by aerobic or facultative bacteria. So enough take only aerobic blood culture. As an investigation, TTP, this is time to positive, should be determined. It assists in the clinical interpretation of blood culture result and is a reason why major guideline recommended discontinue antibiotics therapy if culture remain negative for 36, 48 hours. If result came negative, stop antibiotic therapy. Modern molecular method offer rapid and specific identification of bacteria. PCR is used to detect common specific pathogens. NAS protocol recommended measurement CRP at 18, 24 hours after starting antibiotics. Procalcitonin to support detection on shortening the duration of antibiotic therapy is neonates with sepsis. We start antibiotics therapy. We check CRP and procalcitonin. If during 18-24 hours CRP increase, okay, continue antibiotic therapy and wait result blood culture. If CRP decrease or normal, stop antibiotic therapy. No need continue antibiotic therapy. The same procalcitonin else. CRP and procalcitonin level within the first 72 hours of life serve as admissional markers to help rule out neonatal sepsis. Other investigations, this is high perinatal cytokine levels, migration inhibitory factor MIF, D-dopachrom tautomerase, DDT gene, or domain of migration, microphage migration inhibitory factors, MIF2. Thank you. Two inhibitory factors participate in the biological process. Negative regulation of microphage chemotaxis, positive regulation of microphage chemotaxis, positive regulation of tumor necrotic factor production, positive regulation of inflammatory response, positive regulation to ARK and ARK2 cascade. DDT and MIF2 oppose regulation of adenosine activity, regulation of prostaglandin E2, interleukin 18, plays a role in early life immune response information. Prostaglandin E, interleukin 18, and DDT regulated the tiles balance between pro and anti-inflammatory mediator in neonates, shaping the innate immune response in early life. About antibacterial therapy, most common pathogenesis, group B streptococcus, E. coli, Listeria monocytes, start empirical therapy, ampicillin plus aminoglycoside, especially the gentamicin, sometimes amikacin. Alternative therapy, this is aminoglycosides plus cephalosporins, and especially cefotaxime. Antibacterial therapy, if use cephalosporin long time, this is increase risk of invasive candida. So for premature babies and especially babies with external body weight, with antibiotics therapy, if we use long time cephalosporin, need start anti-candida therapy also. Antibacterial therapy, which cephalosporin choose? Cefotaxime or ceftriaxone? Of course, cefotaxime, because cefotaxime is highly active against gram-negative bacteria, E. coli, Cetobacter, Klebsiella, Pseudomonas. Ceftriaxone don't use during neonatal period because in contraindicated in neonates due to its high protein building capacity, which can displace bilirubin and increase the risk of severe hyperbilirubinemia and kernicterus. So ceftriaxone don't use periods. How long time need use antibiotic therapy? By condition, but not less 10 days. 10 days, 14 days duration. If meningitis, and especially gram-negative, 21 days. If complicated case, more times. Antibacterial therapy, gram-negative, if gram-negative meningitis, cefotaxime plus aminoglycoside. Continue until culture sensitivity results are available. About immunotherapy. Immunomodulators for neonatal sepsis, prevention and treatment, past, present, and future. For infant gestation age less than 32 weeks. Why? So here, low level of passively acquired immunity, low antibody level, insufficient immunoglobulin synthesis. So, which immunotherapy need? IVIG for prevention and treatment of neonatal sepsis. Pentoxifilin, a non-specific phosphodiesterase inhibitor with immunomodulatory property. Glutamine. What about glutamine? Glutamine, this is an endogenously produced, but conditionally essential amino acid, which is reduced under metabolic stress, found in breast milk. Very low level in formula, feeding formula, and we can not use during parenteral nutrition. Yes. Its benefit in neonatal sepsis or necrotic enterocolitis is significant. For immunotherapy, this is last time used usually granulocytes, why need granulocytes low level in neonates, increase the risk, this is increase the risk factor of bacterial infection in neonates. Granulocytes administration in neonatal sepsis may improve the quality and quantity neutrophils, thus enhancing treatment outcomes in prognosis of sepsis. About maternal immunization, this is benefit for mama and for newborn. This is prevention and precaution infection. Increase vaccination, specific immunoglobulin concentration in the mother and enhance antibody levels in the newborn. Which immunization we used, not only we, everywhere. Tetanus, influenza, pertussis, RSV, respiratory syncytial virus, vaccinated are currently used in maternal immunization. Thank you for attention.
Do you have any questions?
Yes. Question? Yes. Please.
Thank you, Dr. for the talk. I was just wondering, are those infants provided with probiotics to maintain microflora of the gut before? Taking so much energy.
Thank you. Thank you for question for your question about probiotics therapy. You know, this bacteriosis, this is not diagnosis. All premature babies delivery by cesarean section, all patients with this bacteriosis. So we know first times, and especially first week, bacteria is not inside. Yes, I don't say sterile. No, not sterile. Low. About this is all guidelines different give different result. One guideline say, okay, start probiotics therapy, but not immediately after delivery. After 1 to 3 weeks after use antibiotics therapy, because we know long time antibiotic therapy оказывает very bad for bacteria inside. Okay, but if you want, yes, please. In our practice, in our clinic, we start antibiotic therapy. If patient on TPN, то есть total parenteral nutrition, of course, no need, nothing, no need. Yes, we wait time when we start feeding. After start feeding, if amount feeding increase, yes, you can start bifidobacteria or lactobacteria cells.
Thank you, time for the session. Just one question. Sorry, about probiotics. We heard earlier that you cannot give probiotics without it becoming with some sort of
Lactobacteria.
Child who's premature, is that a good idea? Because that's giving them cow's milk protein. Why have I got that wrong? Or
So I say, don't start immediately after delivery. Give time. Need time. Grows bacteria inside. Need time. After maybe 2 weeks, 3 weeks.
breast milk is more,
Breast milk better because breast milk inside available bifidobacteria. Mama skin mama has and bifidobacteria and gram and negative also.
I think it's better to start already cesarean delivery.
Yes.
This is cesarean delivery patient already has cannot
take
his mother's period from vaginal tested. So it's better to start with cesarean section. But in extremely low birth weight infants, their intestinal permeability is very high. So it's under question. It's very possible use this probiotic early
Or not. So I say different guidelines. One guideline say, okay, start. One guideline say, wait, need time.
Sure enough to handle it. It's like you said, there's permeability. You could actually give an infection with something that you think you're helping the baby with. That's why it's a big topic of debate right now. Whereas breast milk is all it's always safe and it's made the way it's supposed to be.
All right, thank you, Doctor.
Welcome.
That's what there's.
Thank you.
Next, Mr. President is Dr. Anda United Airlines Race. A medical graduate as the poster title as the head of the writer the Pediatric Children from Georgia. The correlation of inflammation markers to eczema area and severe effects. Please welcome Dr. Watson.
It's on. Hi, good afternoon, everyone. My name is Alia Ikhlaq Modak. And before we start, I just want to give a brief introduction about myself. I am a extremely recent medical graduate. I graduated about 3 months ago. I'm an aspiring pediatrician. And the topic that I'll be talking about today is atopic dermatitis, which is, of course, associated with pediatric dermatology. So before we start, I'm just going to paint you all a picture, right? Think about think about a 6, 7, 8-year-old girl who is going to school in Dubai in the peak heat summer, right? For those of you who don't know, this can go up to 50 degrees, right? So it's extremely hot. And she has a skirt, right? Part of the uniform, but she also has to wear these really thick stockings. And you must be wondering why. And that's because she has this gnarly eczema growing on her leg. I'm sorry for the description, but it really is gnarly. It looks like there's something alive on her leg. And she doesn't want to freak the other kids out, right? It's uncomfortable. She's feeling hot. She has to wear these stockings, and she just doesn't want to. And over a couple of years, with the help of medications and everything, this resolves. Okay. And cut to her turning 24 years old, and thanks to the stress of med school, it's back. And if you guys haven't caught up yet, I have been talking about myself. Unfortunately, I am a victim of atopic dermatitis. Throughout med school, I did want to be a part of something that resonates with me, and hopefully something I can help other pediatric patients out there as well. So we will be assessing the severity of atopic dermatitis or eczema, specifically from children from Georgia. That's where I went to med school, not the state Georgia, but more like the country Georgia. And yeah, the coordination of inflammatory blood markers with eczema area and severity index. So what exactly is atopic dermatitis, right? It is a chronic inflammatory skin condition. Dr. Tracy already did a really good job of explaining the physiology and the pathophysiology behind it. But you have got an increase in immunoglobulin E, the eosinophils, as well as certain cytokines, interleukin 31 being the most important, and I will mention why in a bit. It presents with the pruritus, which is basically itchiness for the ones who don't know, dryness, and inflammation. It is mediated by the immune system, and it goes and damages the epithelial barrier of the skin. So why did we do this research, right? That's the question. So currently, the way that they assess the severity of atopic dermatitis is through a system known as EASI, or Eczema Area and Severity Index. So you have a patient, they have got eczema. The clinician will, have a look at it and they'll give you a score. Okay, based on this, I will give it a score of 6 on 10, or this is going to be a 7 on 10. But what we don't understand is that this is subjective. It is based on the clinician's experience on what they think the scoring of that should be. So we wanted to come up with a way to assess the severity in a more objective way, right? And one way we could do that is by looking at just normal blood counts, a completely normal CBC. What are the neutrophil values? What are the eosinophil values? What are the basophil values? So that's the gap we wanted to fulfill by making, a subjective assessment method into an objective one. So we investigated the correlation between normal inflammatory blood markers and the scoring in Georgian children. So we did a retrospective cross-sectional study, and we were able to find data from patients in 2 clinics in Tbilisi.
which is the capital of Georgia. And we had 22 patients in total, which might seem like a really small sample size, but Georgia's pediatric population is not as much as their geriatric population. So these 22 patients actually are representative of the sample size that is required. And we had children from 8 months to 18 years of age who had a confirmed diagnosis and complete EASI scores, as well as any like incomplete data, or if they have any STIM comorbidities or recent immunosuppressive therapy, all of these were excluded from the study. So again, this might seem a lot, but just to make it easy for you guys, I have like written what exactly those mean down here. But we were able to take the blood markers and calculate their ratios. And we also collected the EASI score by trained clinicians. And yeah, the demographics like age and gender, because we also wanted to see like if you're a girl or if you're a boy, does that increase your risk of getting atopic dermatitis? If, you know, specific gender, specific age. And this is more the statistics part of things, which I'm not going to get into the details of, but we use Pearson correlation and linear regression. We did stats, right? Okay. And the way that the EASI score is calculated is on 4 different things, and this is a little important, where we have erythema, which is redness. We have induration, which is the depth of it. We have excoriation, which is like basically when it's itchy, like how much it has damaged the skin. And we have lichenification, which is like the white strand stuff that is present on eczema. And it's graded from 0 to 3, again, specifically based on the clinician's experience and what they think the score is. So again, this is extremely complicated. I will try to make it as easy as possible. I know we have a lot of doctors and medical professionals here. So I just want you to focus on these red boxes and a little bit on these black boxes. So as you see, we have the EASI score, and with the help of some stats, we were able to correlate it with ERC, lymphocytes, neutrophils, eosinophils, basophils, NLR, BLR, ELR, and this is what they mean. And anything that has a p-value of less than 0.05 means good. That's what we want. That means that there is a statistical correlation between them. And we found that the EASI score and ERC, eosinophils, and ELR actually have a very strong correlation. So that's a good thing, right? We have a subjective way of assessing the score, and now we might just have an objective way of doing it as well. So what we found was that ERC, eosinophils, and ELR had strong positive correlations with the scoring. Another thing that we did was that, as I mentioned, EASI score has got 4 different grading criteria, right? 4 things it's graded on. We took all of those individual ones as well and then correlated it with the blood markers. NLR and BLR, so that's the neutrophils and the basophils, showed weak or non-significant correlations. And yeah, so we did something known as a regression analysis to confirm the findings that we had, and it confirmed exactly what the previous slide said. Okay, so ELR and ERC, they were identified as the most significant blood markers. And as I mentioned in the beginning, interleukin-3, it does act, we already know that eosinophils have a role to play, right, when it comes to things, so atopic dermatitis and asthma and all of these things. And now we know that so does these ratios, like ELR and eosinophil relative count. One thing that we found significant, you might think that, okay, there are studies being done in adults. Why do we need this to be done in children as well? Well, the thing is, we actually did find a difference. So NLR, actually, in adult studies, it showed a significant correlation, but it did not find one in pediatric population, which shows that it might be due to lower neutrophilic activity in children. And again, age and gender had nothing to do. So if you're a male, female, if you're 5 years old, 6 years old, 7 years old, it doesn't really make a difference, right? It does not really have an effect. And regression analysis confirmed our findings. Now, okay, this is the fun part. This is the interesting part. So again, with the findings that we had, we really wanted to make a difference, right? We really wanted to show how our study can do something. So we were able to create, like neuromedical students, we were able to create a model to predict the severity of the EASI score. And this model, or the data that we had, 80% of it was used for training. The model and other 20% is for testing to see if it works or not. And it requires a much larger data set. This is just to show that this is what our research study could possibly do. And it was evaluated using R squared and a lot of applications. And it was built using the random forest model with the ERC and ELR as the input features, because that is what our study found significant. Okay, so our study was, of course, able to find a lot of positive things, but there are certain limitations. At the end of the day, we only did have 22 patients, which in Georgia's population size is quite good, but in the grand scheme of things, if you think about the whole world, 22 patients does seem a little less. And another thing is that for atopic dermatitis, the CBC that is collected, the blood test that is done, it is not routine, right? It's more like opportunistic. If at the time of diagnosis it is done, it is done. It's not something that is routine. And also, there's absence of pre and post treatment values. So we will be able to confirm our findings a lot more if you do these values before treatment and after treatment. And then you can see that, okay, this is something that actually does work and it will confirm our findings. So large scale and multi-center studies are definitely needed. And if we can combine the ERC, ELR along with AI, like creating apps like we did, which we'll get to try in a bit, they can transform AD diagnosis. And yeah, so evaluating pre and post treatment changes is something that was done in the adult population, but not in the pediatric population. And that's something that needs to be done. So you guys can go ahead and scan the QR codes if you want to read our complete research paper, or if you try out an app, you can see how it works. You just have to put in the ERC values and the ELR values, and it'll show you like, okay, there's a high risk of you developing atopic dermatitis, and it'll give you your score as well. Again, this is not to be used in the real world. It is only based off of the findings of our study. But this is what our future studies could do. It would make it so much easier for the clinicians. And I really want to express my gratitude to utilitarian conferences. I'm so glad this is the first conference I could present at as a first graduate. And also I want to thank my university for their guidance and support, as well as my colleagues who helped me with this research. So, any questions? No questions?
Yes, I do have one question. Yeah. So, do you have any control population against which you will be checking these subjects? The 22 patients you have, they are all positive for XMIs, right?
Yes.
So, how do you have a negative control to be check or something like that? Or
no, we didn't have a negative control. We more specifically went with patients who had a confirmed diagnosis of atopic dermatitis and had their EASI scores already calculated. And just to make sure that, we are taking something subjective and turning it into objective. So even that subjectivity had to be lessened as much as possible. So we made sure the EASI scores calculated by multiple clinicians as well.
the patients were under treatment or were they were in the
No, this was at the time of diagnosis. But there's a complete blood count was taken. Okay, that's great. Thank you. Thank you.
That's not business. Okay, our next poster presenter is Dr. Ibrahim Levitt from Ireland, a consultant in pediatric emergency medicine, who will share his poster titled The Prevalence of Bacterial Infection in Recently Vaccinated Febrile Infants. Please welcome Dr. Ibrahim.
Hi, everyone. Thank you for attending this conference. Actually, I have a very quick talk. Me and my registrar, Ali, did actually this study, which is short study over 1 year, just to, everyone hear me clearly, yeah? Short study over 1 year, actually, just to find out in our department just the prevalence of the bacterial infection in those children below 2 years of age. Actually, at the start, we start at below 2 years of age. Then we decide to take the age of 3 months and below 3 months. Because in our department, as I said, I'm working in Tala University Hospital, which is one of the main three hospital in Dublin. And it's busy department. Usually the three departments are so busy, and especially Tala. So we always have these small children below 3 months of age presented to us with high temperature. So some of them actually coming to us after vaccination. So it's very common approach for many ED doctors when, especially in winter time when it's so busy, when he referred, see somebody referred by the GP for high temperature, and he know the history that he is vaccinated already. So he said, okay, this is due to vaccination. Don't worry, especially if the temperature around 38 or below 38, that's why we did the study, because of the lack of evidence in our all the data before or record. We couldn't find anything to say, no, this due to vaccination or not. So what we did, actually, we review our record, our medical record in our department, in our hospital, actually. And we find that take 70 patients, age below 3 months, so age from 6 to 12 weeks. And we try to find those who have temperature of 38 and above. And we evaluate them mainly taking the urine, the first thing, and we evaluate them clinically, which is the right approach. So once you have a child with high temperature, you should examine the child fully. Don't say, okay, this is vaccination, reassure the mom, send her home. That's not acceptable approach, actually. And what we see in this, actually, we have 70 infants we recruit in this study. From January 2018, that study, it's retrospective, actually, from January 2018 until December 2018. So we have 70 infant. And those, usually they have temperature of 38. And most of them, actually, they have no other symptoms apart from fever, which is very common for any pediatrician. Like in emergency department, we have children coming to us with fever only. We couldn't find any focus. We couldn't find anything. So out of those 70, we have 19 children with a temperature of 38 and above, presented within 24 hours to 72 hours. And of them, 11 presented in 24 hours. And 7 presented between 24 to 48 hours. And only 1 presented after 72 hours. Then we evaluate them, we investigate them mainly through culture. So culture, the urine, the blood, and the CSF. Try to find the source of infection in these children. And we find that, the 70, some of them recently vaccinated, as I said, some of them non-vaccinated. So we find is a ratio of 17% to 10%. So 17 non-vaccinated and 10% vaccinated children. We find they have bacterial infection. But interestingly, what we found that those who are recently vaccinated, all of them, actually, they have bacterial infection within 24 hours. So bacterial infection within 24 hours in those recently vaccinated with temperature more than 38, which is very interesting. And then the other thing we find, which is more interesting, all of them E. coli, UTI, E. coli, and responsive to third generation cephalosporin, cefalixin. So by this study, actually, it's a quick one over 1 year. It's not much actually of patient we have, but if you compare over 1 year, you have 70 children, like below 3 months of age, and they have high temperature. That's mean, you know, we put a title of sepsis in those children. So 70 is a good number in 1 year. In a busy department, actually, it's not anywhere. So this study actually, it's published in archive in the British Journal. This study changed our practice, the message to our junior doctors, and mostly to we have fellow actually coming to us from Gulf countries, from Bahrain, from Saudi Arabia. So they took the message with them actually back to here, is that's not to take it easy. Like when you have a febrile child after vaccination, don't take it as simple as due to vaccination. At least try to evaluate them in a quick way, but reasonable way. Take the urine first. Dipstick the urine. If you have even 1+, not a trace is nothing. If you have 1+, send it to the lab. Okay? If the child is, you know, in children, common sense is different with your experience. As much as you work in pediatric department, especially in pediatric emergency department, your skill is different day by day, not year by year. And your approach is improving as the time passes. So the message for young doctor, examine these children fully. It could be otitis media that's causing of high temperature, not the vaccine. Could be anything, chest infection, which is in this age group can present without anything. You do the chest x-ray and you find there is chest infection in that child, or whatever the reason, but it's common, the common is common. UTI is the commonest among these children. So please, send urine for these children and evaluate them, examine them in a quick, nice way. And as I always said to my fellow, to my students, to junior doctors, just take your time with the patient. Means don't take 1 hour examining the child. The minute you enter the room to see the child, you have at least 50% impression this child is sick, or he's going home, or you are going to admit him by looking at the child before you touch him. I always said again about the stethoscope in children. Sometimes it's useless. Don't depend on stethoscope. We very, very much like don't touch our stethoscope. And if we use it, it's not much. The feedback from the stethoscope is much less, okay? Depend on your experience, your common sense, and try to, as I said, those small children, examine them well and fully from the top to the bottom, and take less than 5 minutes to do that. It's simple. If you have the message, I will say, if you have no clue about the child you are examining, within a few minutes, you need help. Ask for a second opinion. And thank you. If you have any question. Yes, please.
Good. The AAP and the ACIP are recommending. So you think that, because every time you put a catheter in baby, you give it a 1% chance of getting a urinary tract infection. And sometimes you have to do a suprapubic because the bag isn't reliable.
That's right.
Yeah. It'll be, because I think a lot of kids will get a workup that they don't need. I don't mind getting blood culture, but spinal fluid and the urine, they're a little more aggressive than babies. I'm just.
Oh yeah. No, I agree with you. What you're saying. Well, what you're saying is right, and but my message is a little bit different. I said at least take a urine sample from these children. Taking CSF, doing lumbar puncture on those small baby is not easy. It's hard. Okay, it's hard for the family, for the mom looking at you puncturing her child in the back. It's hard for everyone actually. So unless you need it, so it's different. Again, how many times you are decided without any sign and symptoms, you decide this child is very sick, I need to admit him. Many times. And this is about pediatrics. It's not happening in adult, by the way. It's only in pediatrics. Pediatrics is different. The approach is different. So your common sense, you decide who need further investigation more than the urine. But in general, I said, do the urine, okay? But if you look at the child is lethargic. The child is not fully alert. He's not responding well. He's not well hydrated. Then you jump to the other things. You may reach the lumbar puncture. So it's depend on you. The approach is more personal, more depend on skills, more. I'm not myself when I graduate, like years back. I'm not going to say the years. Since I start in Ireland in 99 until now, I'm not the one who started in 99. Different. Every day I'm still learning, even I'm the most senior in the hospital, but I'm still learning from myself, learning from. I just give you 1 minute extra. Sorry for that, for the time. Just before I came here, there was a lecture or a mention of diarrhea and vomiting. A child with diarrhea. I don't know who mentioned that actually. And say at least, sorry. And you said at least give them oral rehydration and send the child, home. And if 3 days, if not improve, child in 3 hours can be very sick, and even in diarrhea and vomiting. Okay? So in a few hours, he can collapse like that after diarrhea and vomiting. So it's not a rule. Don't take it as a rule. As, sorry, what's your name? Fatma. As Fatma said, send him home. If in 3 days, if he's not improved, ask the mom, give her advice to come back. No, it's not a rule. Yes, yeah, I know what you mean. But some of the people take the message in a way like differently. These children can be collapsed in a few hours, actually, not 3 days. Okay.
Things that you can use, maybe a blood check.
Oh, we did the block, of course.
Well, and they generally.
We don't. Yes. Yeah, we don't use the bag anymore. We don't use it. It's contamination. So I usually, what I do now, I clean the area from here down with water only, without soap. I ask the mom, do this, please, in her room, in privacy. And I said, do and clean collection. That's a clean touch. That's the best way. And urine always like a good answer for a lot of things. Sometimes it's not. Sometimes it's a bit confusing, actually, especially in children with diarrhea and vomiting. It's contamination there. So it depends, again, if you clean the area very well, especially in girls, then you are going to get a clean catch, which is okay. We don't do suprapubic, actually. We don't do it, like many years now. Yes.
And they don't. I look at the urines are read incorrectly. They're collected incorrectly.
Yes.
They don't.
I agree with you.
Wow. A UTI.
Yeah. Yeah. Yeah, of course. No. I agree with you. But these kind of like abnormal finding usually depend on the organism, proteus or whatever you have abnormal bacteria or something. Then you think of, and depend on the age of the child. Then what's our family history? You go further for investigation in these children. It's depend on a lot of things. But as I said. Do the urine at least, and children is different from adult, so take it easy. Diarrhea and vomiting doesn't mean always gastroenteritis. As I said before I came here, at the night I have a child with diarrhea and vomiting. I give him bolus, I give him fluid, and I ask the registrar, how is he? He said he's still unwell. So I went to the room. I didn't see him, but the first time he discussed it with me, the registrar, and then I give him the advice to do what to do. Then when I went to the room, immediately I decide it's not simple diarrhea and vomiting. Why? The position of the child. He was sitting on the edge of the bed and bending like this. I said, what's going on? So that's why I said, you look. So the minute I opened the door, I found the child sitting. I said, okay, what's wrong? Left side, abdominal, not right. Left side, abdominal pain. And he's 9 years old. So you're not talking about a girl with ovaries or something. So left side, okay. Is the appendix can be retrocecal, can be behind the liver, can be on the left. Yes, can be anywhere. Okay, and that's acute appendicitis about to rupture with severe diarrhea. It's watery diarrhea and vomiting. So it's all about, it's as I said, with years, you are going to make decision within 2 minutes, maximum, or if not 1 minute. If you are delayed in your diagnosis, please, more than 3 or 4 minutes, ask for help or from senior. Yeah. Yeah.
Massive bleeding and bruising within the of the intestines.
Yeah.
The father, who was a policeman sitting next to him, had kicked that child.
Oh yeah, can happen. Yes. Yeah.
It's always consider safeguarding.
Yeah. And the child present with diarrhea and vomiting?
He presented with a number of factors.
Oh, yeah. But the reason I brought in this case because of Fatima presentation, diarrhea and vomiting. As I said, like simple diarrhea and vomiting, but can be something else. Anyway, it's a lot. Pediatrics is very. You see it very abroad, like in every area. But as you're getting older, as you're getting more senior, as you're getting more experience, you see it the simplest and the lovely branch. That's it. Thank you very much. Okay. Yeah, you have a more question, please. Okay, that's it. Yeah. Excellent. Thanks.
The speaker is Ms. Sarah Elaborate, very titled Severe Bacterium Falciparum malaria complicated by artemisinin delayed hemolysis in a pediatric patient. A case report and literature review. Kindly welcome Ms. Sarah.
Assalamu alaikum. My name is Sara Galadari. I'm a final year medical student at Mohammed bin Rashid University, and today I'll be presenting a case of severe Plasmodium falciparum malaria complicated by post-artemisinin delayed hemolysis in a pediatric patient. Our case highlights that even with successful treatment of malaria, patient can have delayed hematological complication that requires close follow-up. So starting with our case, our patient is a 9-year-old boy who presented with high-grade fever and vomiting for the past 4 days after returning from Tanzania, which is considered a malarial endemic region. Patient is otherwise healthy, no past medical history, non-significant family history, no known allergies, and his vaccinations are up to date. On physical examination, the patient was jaundiced, pale, dehydrated, and tired looking with documented high-grade fever. On abdominal examination, patient had mild hepatosplenomegaly, which is more consistent with severe malarial infection. Moving on to the lab investigation, peripheral blood smear confirmed that the patient had Plasmodium falciparum with 6.1% parasitemia, confirming that the patient had malarial infection with a high parasitic load. Liver function was also deranged, which explains the patient jaundice. His serum creatinine has also peaked, indicating that the patient was suffering from acute kidney injury. He also had mild anemia, probably due to the malarial infection infecting the red blood cell. His hemoglobin was 10.8. And last but not least, the patient had severe thrombocytopenia, 16,000, which was very severe, grade 4, and he didn't have any bleeding manifestations. So the patient was treated with 2 units of apheresis platelet to correct his severe thrombocytopenia and symptomatic treatment for fever and pain, as well as IV fluids to support his hydration as well as correct the kidney injury. And for his malaria, we treated him with IV artesunate followed by oral artesunate when the patient was able to tolerate orally. So this is just a graph that shows the parasite clearance. So as you can see, when the patient presented on day 1, the patient has 6.1% of parasitemia. However, it has recovered fully to 0% on day 3. So this suggests a good response to artesunate. So the patient was stabilized with treatment and he was discharged. On discharge, his peripheral blood smear was negative for malaria. His liver function test was almost back to normal. His jaundice has subsided. Serum creatinine also came back to 0.54 and his hemoglobin was almost normal, 12.7. And platelet, post 2 units of platelets, his platelet count was 225,000. Unfortunately, this boy was unlucky and had to be readmitted again 4 days post-discharge. The patient was readmitted due to fatigue, pallor, mild jaundice, and cola-colored urine. Despite having a negative peripheral smear with no malaria infection, his hemoglobin has dropped to 7.4, and there was signs of hemolysis with elevated lactate dehydrogenase increased indirect bilirubin, and high reticulocytosis. So we diagnosed the patient with PADH, which is post-artemisinin delayed hemolysis, which is a common phenomena seen with artemisinin therapy for malarial infection. So we treated the patient with supportive management. We admitted him to the hospital. We gave him some blood as his hemoglobin was 7, and he had a full hematological recovery where his hemoglobin went back to 15.9. So moving on to discussion, artemisinin is a very effective treatment and is considered the first-line treatment for malarial infection. However, it does have a dual nature. So it's very good in terms of rapid parasite clearance. However, it do cause PADH. There is a large cohort study in Spain that showed that 4 out of 21 patients that were treated for severe malaria after IV artesunate developed PADH 9 to 14 days post-treatment, and they were all managed supportively. Even in our case, our patient was treated with IV followed by oral. However, there are in literature some cases that were only treated with oral and developed hemolysis. So there's this case which basically was treated for 3 days of artemisinin combined therapy, and 37.4% of patients had signs of hemolysis with increased LDH, decreased haptoglobin, and reticulocytosis on day 14. There are more severe cases where a patient had symptomatic anemia and one rare fatal case of delayed onset hemolytic anemia. So this patient developed hemolysis post-artemisinin therapy. However, he declined transfusion and ended up with dying. So our case is very important because it demonstrates PADH not only after IV, but IV followed by oral. So it suggests that PADH is not only exclusive of IV, but also can happen with oral therapy. And our case is it's likely to be the first pediatric case report in a PADH patient in a non-immune traveler. And it emphasizes malaria prophylaxis for children visiting endemic area. And non-immune children are vulnerable to have severe malaria and side effect of malaria treatment. So what do we recommend clinician is to basically check the patient hemoglobin and hemolysis marker up to 14 days post-treatment to enable early detection and intervention. So our case is important because even though PADH is self-limited, however, severe anemia and rarely fatal outcome highlights a need for structured follow-up. So in conclusion, PADH is uncommon, however, it's clinically important and can cause death in pediatric population. Increasingly recognized after both IV and oral, and hemolysis after treatment for uncomplicated malaria can be up to 2 weeks. Some cases might be severe enough, as our case, that may require hospitalization. So our clinical recommendation for clinician is to have a high index of suspicion and a close follow-up for patients treated with malaria, specifically in children, pregnant women, patients with pre-existing anemia, and children with high risk of anemia-related complication, and just follow up closely these patients after the ACT therapy. These are my reference, and thank you so much. Questions? Thank you.
The next poster presenter is Ms. Shama Rao and the Great, with a final-year medical student titled Urology Robotic Surgery in Pediatric Daily Affairs, Many Clinics Within Hospital Midwife and UAE and Initial Evaluations. Please welcome Ms. Shama.
Hello, everyone. My name is Shama Lutaf. I'm a final year medical student at MBRU.
and today I'm thrilled to share our team's project, the first documented series of pediatric robotic urologic surgeries in the UAE, conducted at Mediclinic City Hospital. This study explores how robotic technology, something long proven in adults, can transform care for pediatric populations right here in the UAE. So robotic surgery offers a few big advantages over traditional laparoscopy. Things like 3D magnified vision, tremor filtration, and wristed instruments that mimic human hands dexterity and improves overall ergonomics. And these factors are game changers, especially when you're operating in tiny pediatric anatomy where precision really matters. Globally, robotic surgery is well established, but in the UAE, especially the pediatric field, we're still catching up. Our main question was very simple. So we wanted to determine the feasibility and safety of robotic-assisted pediatric urologic surgery within a private hospital setting in Dubai. And to answer that, we had three aims. The first is to evaluate the feasibility and outcomes. Basically, can we do it safely and efficiently? The second, to assess cosmetic results and satisfaction of the parents and patients. And lastly, is to provide baseline data, something that can support future regional research and help other centers adopt robotic surgeries. The way we did this study is we conducted a retrospective review of all pediatric robotic urologic surgeries done at Mediclinic City Hospital between February 2021 to March 2023. And we had 8 patients, the age ranging from infants up to 15 years old. And the procedures involved 6 pyeloplasties, 1 nephrectomy, and 1 adrenalectomy. And we analyzed the operative time, hospital stay, and complications of these procedures. This is a little bit about the robot we used. It's the Da Vinci robot, and the trocars are the 8 millimeters, which is actually for adult patients. Now, for the results, all 8 procedures were completed entirely robotically with no conversions to open surgery. The average operative time for the robotic pyeloplasty was about 2 hours, including docking and undocking, which takes about 20 to 30 minutes. And when you compare that to standard laparoscopic surgery, it's about 2 to 4 hours. So we can say that the robotic surgeries are within the shorter range of time. And the mean hospital stay was roughly around 1 day. And there was no intra or post-operative complications, and patients achieved excellent cosmetic outcomes, and the families were interviewed afterwards and then a few months after in their post-checkup, and they consistently reported high satisfaction, mainly due to the shorter recovery, minimal pain, and barely visible scars afterwards. When we benchmarked our outcomes internationally, they matched what's reported in established centers around the world, which shows that robotic urology is both feasible and safe. Right here in Dubai's private sectors. Of course, we still face a few barriers. First of all, the cost of the technology. It's very expensive to run a robotic surgeries in the hospital. The second is the very steep learning curve for surgeons. It requires a lot of training, but once the surgeon's able to overcome and flatten the curve, they're able to do many complex procedure and maneuvers. So it's pretty interesting. And the fact that the instrument sizes are optimized for adults. This is one of the major issues, but these are challenges of accessibility and logistics rather than safety or efficacy of these patients. So the success of our research opens a door to exciting new steps. So we have a few implications that we would like to discover. The first thing is the miniaturization of the instruments. So as I explained, we were using the adult 8mm trocars, and that's a bit big. Especially when you're dealing with infants, and the fact that we need about 4 ports for these patients. So the typical laparoscopic ports for neonates and children are 3 to 5 millimeters, which is way smaller than what we used. And if we do that, that's going to improve, that's going to show major improvement in complex maneuvers and prevent any collisions and crowding of the external arms. And then we can expand the access to the younger pediatric population. We'd also like to see a structured pediatric robotic training, like a curriculum, so that future surgeons can adopt these skills and shorten the learning curve. And we can expand to other specialties, not just urology. We can go to like pediatric oncology and general surgery. And we'd also like to see a regional outcome registry being formed so that we can track results, share data, and improve standardized across the Gulf. So essentially, we've shown that it can be done. Now the focus is making it widely available. So to wrap things up, this represented the UAE's first series of pediatric robotic urologic surgeries, demonstrating safety and feasibility and excellent outcomes. And it's an encouraging step forward to pediatric minimally invasive surgery in the region. And thank you all very much for your attention.
Like, it's interesting to know about the robotic surgery, like to extend it to our hospital as well. Well, can you join for the certificate? Oh, yeah.
Yeah. That's great. Yes, okay. Level. Thank you.
So our last speaker before the lunch break is also it's not going to start there and so my medical student from the UAE. Her poster presentation is titled Spinalian Crypto Clock Research Syndrome, a literature review and phase report of a very clinical entity. Please join me in welcoming Ms. Malcolm.
Good afternoon, everybody. My name is Hamda Kalantar, as I was already introduced. I'm a final year medical student from Mohammed bin Rashid University of Medicine and Health Sciences. And for today's topic, I would like to bring to your attention a very rare and not very commonly reported and clinical entity. And with that, hopefully we can bring more awareness and help to diagnose it more in the future. Okay, so first of all, I would like to start with an abstract. So what is it about? So Spigelian cryptorchidism is a rare neonatal condition where we basically have a Spigelian hernia, which is a hernia between the semilunar line and the rectus abdominis, and an ipsilateral undescended testis. And often we don't recognize it on radiology. It's very easy to miss. So we usually depend clinically on assessing neonate and finding it. So we would like to present a full-term neonate male delivered via QE-assisted vaginal delivery after fetal bradycardia. And on examination, we found that he had bilateral renal pelvic and undescended right testis. So this was antenatally. And then postnatally on examination, we found a partially reducible sausage-shaped mass, which was noted in the right lower quadrant. Okay. So for introduction, first we have a Spigelian hernia. So I mentioned it earlier, it's a defect in the abdominal wall along the semilunar line, and it usually accounts for less than 2% of all the abdominal hernias. And it's very rarely congenital and even rarer in neonates, with less than 100 cases reported worldwide. So Spigelian cryptorchidism syndrome is basically the combination of the undescended testis with the hernia both on the same side. And there are 3 different theories as to why this happened, and I would like to approach them more during the discussion. Okay, so first, let's start with our case presentation. This is our baby boy, and that's the sausage mass that he presented with. And on examination, the right side, the testes was not palpated. And As you can see, for birth parameters, he was very much healthy. There was nothing of importance to note. Just the antenatally, he did have a bilateral renal pelvic thesis. And for the abdomen, it was soft, it was non-distended, and his mass would be more prominent with crying. So when this picture was taken, he was actually crying. So as you can see, it is bulging. And ultrasound was done on 2 different days, so day 1 and day 3. Because if you remember earlier, I mentioned that on radiology, it's very easy to miss it. So on the first day, we were only able to see that he does have an intra-abdominal testis, but we could not necessarily see the mass defect in the abdomen. And for surgical evaluation, the mass would be measured around 8 by 5 centimeters, and it was reducible. So, and as if you can see, it's above the inguinal canal. So that's why we diagnosed it with a scapular hernia. So these are our findings on day 3. So we had another ultrasound repeated. And the first picture on top, that's the testicle in the abdomen. And down there, we can see the defect, which measures 17 millimeters, that we actually missed on the very first day. But when we did it again, we had a radiologist as well interpret this imaging a bit more in detail. And that's when we came to find the defect. For management, we decided to wait and observe our baby because we want to have the surgery done in an easy way and while delaying other risks. So we opted for an elective repair at 12 months, so when he's 1 year. And our rationale behind that is to first minimize the anesthesia risk for infants. And we also want to allow us for better handling of the anatomy. And with that, we can also have other disciplinary approach that is helping us along the management. So we're going to involve a neonatologist, a pediatric surgeon, a radiologist, and a urologist to better manage this patient holistically. And we will continue monitoring the patient as we do not want to miss an incarcerated hernia along the way or any atrophy to the testicle. So for my discussion part, first and foremost, I would reiterate my point that ultrasound might miss this condition. So it's very important to rely on your clinical skills when assessing a child to help pick that up. So clinical examination is the cornerstone of this diagnosis. And there are 3 embryological theories, which I mentioned earlier. The very first one is a developmental arrest. So both the testicle and the abdominal wall develop around 8 to 12 weeks of gestation. So that could maybe add on to why we have both the abdominal wall and the testicular descent both at the same time. Another theory is that there's another facial defect going on that could divert the testicle. And for our case, that's where we usually want to move towards. So we have the diversion theory because we did find a facial defect of 17 millimeter. And then lastly, we have the trapping theory, which basically means that the hernia is not allowing the testicle to descend. So there's nothing wrong per se with the testicle. It's just that the hernia is blocking its descent. And for management, we don't delay surgery, of course, unless there's an incarceration or we are worried about risk of testicular atrophy or vascular compromisation in the child. That's when we would prefer to have the surgery earlier. However, other than that, we would prefer to have it done around 12 months. And with that, we highlight an importance of a clinical radiological correlation and a high index of suspicion. So I don't know why it's not showing up, but we had other case reports collected from the ones online. But basically what it showed that most of them missed the hernia and the defect on ultrasound. And most of the cases reported a right side of the undescended testis and the hernia. So rarely do we see a left side. And then 2 of them opted for open surgery, while 2 of the ones we mentioned opted for laparoscopic, but both of them had very similar outcomes. So on post checkup, the child was very much healthy, normal, and they all started going to school and no complications was reported. So this is my conclusion. It's very much similar to what I just mentioned and talked about. So in the very end, what I would like to bring to your note is the importance of this very rare diagnosis and how it's very important for us to clinically assess the child, because that's how we would pick it up, and not necessarily depend on ultrasound, as it might not necessarily give us the answer that we're looking for. Thank you.
That's great.
We'll break for lunch now. Let's come back.
Okay, that's 4 minutes slide. So yeah. Right. Yeah. Okay. Thank you. Thank you very much. Oh, okay, so you might in that culture. Okay. So, no. Yes. Is it? Yes, we have it. So. Yes. Yes, yes. So when I don't make course, yeah. How? Thank you. Thank you. Oh, good. Who's ready for our very good. Some maybe. Yeah, I mean now this is one next. Oh, this is what the issue is. He's 100% the father. Yeah. Sure. So naturally, no. The organizers are sure. Thank you. Bye. Thank you. Likewise. Say, I'm so glad I met you. We can keep in touch. Yeah. You did. Yeah, I told her. I love her. My one of a very, very close friend is someone there, yeah.
but her mom is already in her dad is living. And she is also here's why here's why. I love her so much. I'm like, that's what I love. I keep that it's really nice. Thank you so much. Thank you. Thank you. Thank you.
Come koydu orada. Gel koydu açık için.
Çok yok biraz.
Bir de bak benim seçtiğim rica ederim. Hasan geçiriyorsunuz. Geçirmeyi. Ele Sıcağına güzel bir şey geldi. Orada. Aynen de yok. Diyen. Lan. Kim gelir oradan gelir. Döndü. Buradan döndü. Zıp değişiyorsun. Burada. confirm with the diagnosis include the following steps. We run a screening test.
This meeting is being recorded. In progress.
out transference in the heart, and there is the transference as part of the transfer 2100.3. Creatine kinase is enzymes of the muscle is normal, and total creatine is normal. And the glucose starvation is normal. Bilirubin total a little higher. Direct bilirubin 2.21, and infection is negative. All of the infection is normal, negative. And abnormal ultrasound, labor caudal lenses to 125 millimeter, a little high, and parenchymal agonicity is increased, and the structure is granular. Spleen caudal dimension is 70 millimeter, a little high. The cardiogram normal, not change this little, and the little change in the same. And in these babies and the children, it's often ocular pneumonia. Pneumonic episodes are observed on the chest X-ray. The heart borders you see are often normal, and the chest not resonant. Okay, we check the patient's voice analysis and the genome analysis, and the patient was found to have a genetic mitochondrial diseases. Well, exams includes analysis from the patient's peripheral blood we have taken. And this one is got this is variant in CGN2A. This and is the several genetic cancers, developmental and epileptic encephalopathy 11, and episodic ataxia type 9, benign femoral infantile sway, and several genes are found on this children in this baby. And what about the MRI? How common pattern of brain MRI imaging mitochondrial disease with complex foundations? There is a abnormal signal intensity in the brain stem and substantial nuclei along with a lactate peer. And this baby, when she was she has like chronic like scissors. She has hypotony and development in line. And when she was 1 year, this chronic scissors. Sorry. What are the neurological symptoms of mitochondrial diseases? This deficiency caused by genetic mutation in our mitochondrial genes can result in neurological issues such as encephalopathy and seizures, muscle problems like fatigue and low tone. While there is no cure, but can include dietary interventions like a ketogenic diet for certain cases. What about the ketogenic diet? Treatment is symptomatic and supportive, which may include a ketogenic diet to help manage symptoms in some cases. The ketogenic diet is a low carbohydrate and high fat, fat. The goal of this diet is to put the body in the state of ketosis, where fat is used as a source of energy instead of carbohydrates. On a keto diet, you will focus on foods like meats, fish, eggs, and others. But you must also avoid high carbohydrate foods such as grains, rice, pasta, and sugar foods, and starchy vegetables like potatoes. It is not specific treatment, but symptomatic support is essential. Mitochondrial support supplements such as coenzyme Q10, lipoflavin, thiamine, biotin, carnitin, and ketogenic. These all special treatment that's included in this treatment. Nutrition to energy needs, physical therapy, and neurological monitoring. Since these diseases are accompanied by severe energy deficiency, early diagnosis and multidisciplinary approach are crucial. How long do people with mitochondrial diseases live?
What's the prognosis for individual affected by mitochondrial diseases? That's a tough question. To answer because the prognosis depend upon a variety of criteria. Some affected children and adults are living fairly normal lives. In other cases, affected children may not survive beyond their teenage years. Can mitochondrial disease cause weight gain? Consist with a mitochondrial rule. Primary mitochondrial disorders can also affect body fat storage, leading to multiple symmetrical lipomatosis. Can mitochondrial disorder be cured? While mitochondrial disorders have no cure, children often do better when symptoms are caught and addressed early. What to avoid with mitochondrial diseases? The following medications should be avoided in patients with mitochondrial disease when possible: alprazolam, statins, metformin, high-dose acetaminophen, and selected antibiotics, including aminoglycosides, inositol, tetracycline, azithromycin, and erythromycin. These are patients that we are following. Our developed patient who we are following is now 1 year, 2 months old, weight 5.2 kilograms. Since birth, they have managed to increase the weight by 4 kilograms. Sometimes she has a seizures. She's hypertonic, respiratory system diseases are in remission, and the liver and the kidney function are still well. It consists of the purpose of this work. It consists in the early detection of such pathological conditions among newborns, which helps to prevent various degrees of disability and death. This city, we will be happy to see you in Baku, beautiful city of Azerbaijan. Thank you for your patience.
Thank you, Dr. Hillary, for the wonderful talk. Do we have any questions? Yes, we have a question.
These babies only we should only keep the diet, ketogenic diet, not to improve the diabetes and this the high carbohydrates we can avoid high carbohydrates. All the fat, this diet at first. And there is some supplements that poison Q10, riboflavin, thiamine. These supplements will getting better, should getting better, yeah. And we only 3 or 4 kilograms can get weight for this.
I have a question as well. So, because mitochondria is inherited from the mother generally, I mean, not generally from the mother. So, is there a predisposition from whether the mother had a problem or was it inherited from the mother, or because it's a genetic disease, right? So, was it inherited, or do we have any ideas about that?
No, the mother has inherited diseases. She's a normal, a normal pregnancy, but the father and mother is contagious. That's why the genes mutation is getting, and there is several mutations, not only mitochondrial diseases. There is a encephalopathies type in the genes analysis. There is several genes mutations.
And are there any newborn screenings that you have in the hospitals to identify these kind of diseases? You have like
we put initial analysis on from the genes exome analysis already. And this clinic is approach to maybe the diagnosis first, but it is only this for the rest analysis. We can't take this one. Diagnosis.
All right, thank you so much. We have your certificate. Kindly use it. Our next poster presentation is by Dr. Arshia Sehar Hashmat from UAE, a trainee at Dubai Hospital. She'll present her poster presentation on a case report on congenital systemic candidiasis in a premature neonate, extreme preterm infant. Please join me in welcoming Dr. Arshia.
Good afternoon, everyone. I'm Dr. Arshia Hashmat. Firstly, I would like to take this opportunity to appreciate the efforts that have been made by the organizing committee and Dr. Lisa especially, because truly both the days have been quite productive and educational. So yeah, let's proceed ahead. I'm Dr. Arshia. I've done my medical graduation from India and I'm aspiring to be a pediatrician, inshallah. And I have done my current training from Dubai Hospital, which is under the bracket of Dubai Health, under the guidance and under the guidance of my consulting physician, neonatal consultant, Dr. Yasser. We have conducted this case report. So let's begin. Our case report is a case of a baby, a newborn preterm, extremely preterm infant who presented with complaints suggesting of congenital systemic candidiasis. As we know that systemic candidiasis is quite rare and the chances of survival in this particular fungal infection is pretty low, especially most commonly affecting the preterm and extremely low birth weight infants. So as per my statistics that we took the literature reviews, we have found out that most of the infants who present with this condition have a birth weight of lower than 1 kg. So most commonly noticed key maternal and perinatal risk factors include the maternal vaginal candidal colonization, premature rupture of membrane, which is most common causative factor, lack of antenatal care, and prematurity and low birth weight. So let's proceed. The most common causative organism, the most causative fungal infection is associated with Candida albicans species. And these babies, the premature babies, are extremely vulnerable because they're mature, they have so much. They face a lot of metabolic challenges immediately after birth. They have dehydration, hypernatremia, hypoglycemia. So they are immunologically really compromised. As such, there is an increased demand for invasive NICU procedures in these babies. So as a result, they are more vulnerable to infections. So our case presentation talks about a male infant who is born at 26 weeks of gestation, who presented with born via spontaneous vaginal delivery outside the hospital, as a result of which we are not aware of any antenatal screening and antenatal history of the mother. And she was an unbooked patient, so we are not sure about under what circumstances her pregnancy went through. And there was no known maternal infections that we had reported. So the only thing that we know pertaining to the mom is that she presented with premature rupture of membranes, which resulted in her premature delivery. So the baby presented to the emergency with respiratory distress, requiring immediate resuscitation and intubation and surfactant therapy. There was the significant standard condition situation that we would actually face in a preterm baby, presenting with lethargy, poor perfusion, hypothermia, as a result of which the patient was admitted in the NICU. And initially, the provisional diagnosis which was suspected was the usual most common finding, which is an early onset bacterial sepsis condition. But further on, later on, we discovered something else. Our most top differential diagnosis was an early onset bacterial sepsis or a viral infection. So through the initial clinical course, the baby, we started the infant on broad spectrum antibiotics in the emergency. The baby was given gentamicin and ampicillin, but there was no response to it. And there was rapid respiratory decline, and also, but still the C-reactive proteins was elevated, which suggested a septic picture, having, but like making sure, like indicating that the baby was having an ongoing infection. So, further relevant investigations, the complete blood count was done, which showed fluctuating leukocytosis, further indicating that there were signs of infection. Initial X-ray showed diffuse granular brown glass appearance with air bronchospasms, which suggested respiratory distress. The C-reactive protein was elevated, indicating active form of infection. And as a result of this, we had to lean in towards other possible causes, because we couldn't, since the baby was not responding to the initial antibiotics, we had to think outside the box that it could be more than bacterial sepsis or a bacterial infection, because it's a the form of exposure was through premature membranes. So we have to analyze the vertical transmission causes of infection, which could indicate the possibility of candidiasis. And as such, we conducted the blood cultures, which was taken immediately as soon as the baby was brought into the NICU, and which actually result with what came out positive for Candida albicans. There was heavy growth seen in the blood cultures, and also the baby presented with diffuse erythematous rashes. And there was peeling and desquamation noted, especially over the abdomen and the chest area and the upper limbs. There was significant skin peeling and desquamation, which also suggested the chances of cutaneous manifestations and involvement. As a result, now that we have figured out that it is a case of Candida albicans, we have to rule out whether it is systemic or it could be a neonatal growth, or what the type of what do you say, the type of and the stage of the progress of the infection. So as such, we did the skin swab, which also showed the heavy growth of Candida, suggesting cutaneous manifestation involvement. Cranial nerves and urine cultures were negative, which showed that there was no cranial nerve involvement, or urinary tract did not have candidiasis. Further on, the eye examination was done for ruling out any, or mainly we had to rule out disseminated candidiasis involvement. So we had to rule out the chances of any multi-organ involvement in candidiasis, for which we did the eye examination, echocardiography, and renal ultrasound, all of which came back negative. So our baby was diagnosed with systemic congenital candidiasis. Furthermore, in the NICU, his symptoms were complicated with respiratory distress syndrome. He had intraventricular hemorrhage, feeding intolerance, and also anemia. And he also presented with patent ductus arteriosus. Later on the ophthalmology scans suggested retinopathy of prematurity, all of which spontaneously resolved over his course of treatment in the hospital. Pertaining to the fungal infection, which is our condition, the baby was started with amphotericin B as the antifungal sensitivity testing suggested that he was resistant to azoles and sensitive to amphotericin B. So amphotericin B was our game changer. It was the main treatment protocol which we gave for about 3 weeks, which is also considered as the gold standard treatment for systemic candidiasis infection. And throughout the course of the hospital, there was significant clinical improvement that we had noticed, and there was decline in the progression of infection. Initially, as the baby was started with surfactant therapy and mechanical ventilation, he was reduced, which was shifted to CPAP by third week of admission, and also by room air. The patient was, the baby was able to breathe by itself by 10th week of admission. So there was supportive therapy which was given. We gave the multiple blood transfusions which was required for anemia treatment. Initially from parenteral nutrition source, he was gradually his tolerance level improved, as a result of which he started with oral feeds. And follow-up was very essential. Even during his NICU stay, we made sure that the multidisciplinary team action was involved, as there was frequent follow-up with the neurology, cardiology, and ophthalmology, just to make sure that the symptoms of this child doesn't worsen up. So this was our timeline, because when it comes to congenital candidiasis, the chances of survival of this baby is very, very low. So we did everything possible to make sure that the child survives and leaves the hospital happy. So our outcome meant the patient was admitted, the baby was there in the NICU for about 146 days, but upon discharge, the baby was stable. Weight was around 4.1 kgs, which is a very good achievable goal for us. And he was breathing under room air. There was no, the growth and development of the baby was appropriate for his corrected age, and there was no disseminated infection or any chance of reoccurrence. So our study turned out to be successful. Our case report was successful, as the baby had a complete recovery. So less than 75, if you see the statistics, worldwide there are less than 75 reported cases of systemic congenital candidiasis, out of which the mortality rate remains very high. It's around 35% to 45%. So the chance of survival and making sure that the baby lives longer is very crucial. And that's why this case is very optimal or very important, because it helps us to understand that early recognition of fungal sepsis is very crucial, and this plays a very crucial role. So yeah, when we the key learning objective from this case report is that always suspect fungal sepsis when neonates are unresponsive to the broad spectrum antibiotics, and early fungal cultures and susceptibility testing are very crucial in preterm infants. Amphotericin B is still considered as the life-saving first line when azole-resistant cases are reported, and multidisciplinary NICU care is very crucial because the chances of survival keeps declining in these babies as their stay in the hospital prolongs. So crucial monitoring is very close monitoring is essential. So as such, early suspicion can only lead to early survival. If you do not suspect, there is no chances of surviving for the baby. So don't narrow down your mind, and think about all the possible scenarios, especially when it comes to pediatrics, because nothing is predictable when it comes to kids. You will think of something, but the manifestation, the clinical picture will go to some other direction. And by the time you figure out, it will be quite late. So early recognition is life-saving. So this is the abstract that we have submitted, and waiting costs lives. So yeah, thank you. Yes. Okay, thank you. There are certain apps, illustration apps, where you can describe like what you want to achieve for each slide, and they make the illustrations very easy. Yeah. Yeah, yeah. Thank you.
So the next speaker is Shara and an educator in Congress. The topic is Development of Active Efficiency of Medicare Schools. Please welcome to the show.
Hello for everybody. Today I will present you one of our patient with molybdenum cofactor deficiency. As molybdenum cofactor deficiency is one of inherited metabolic disorders, first I would like to give a short introduction. His inherited metabolic disorders can occur with some neurologic symptoms like seizure, development delay, mental deterioration, cranial nerve deficits, and motor disorders. Epilepsy associated with inherited metabolic disorders has usually features of catastrophic encephalopathy because they start very early, sometimes from first days of life, and these seizures usually refractory to conventional anti-epileptic drugs, and very often epileptic activity is associated with severe cognitive, sensorial, and motor function degradation. Metabolic epileptic encephalopathies display an age-dependent susceptibility and clinical phenotype. So epilepsy phenotype can evolve over the time, and to fit description of different types of the different syndromes of epilepsy syndromes. But several inherited errors of metabolism are treatable. So, and if you treat these seizures, if you treat metabolic disease, you can control the seizures, and early diagnosis is very important because if you make diagnosis, you can prevent complication or at least severity of complication. And even if there is currently no treatment for this metabolic disease, making diagnosis is still important because it help you guide treatment of this management of this condition, and provides you a clearer idea about prognosis of disease, and allows you accurate advice at the risk of recurrence and how to prevent this recurrence. There are more than 2 different metabolic disorders associated with epilepsy, and some of them, especially in newborn and infants, epilepsy is the predominant clinical manifestation, but sometimes epilepsy is one part of the broader clinical spectrum, including extra neurologic signs such as cutaneous, skeletal, then sensorial, motor, and metabolites. And presence of extra neurologic signs, it's very important for diagnosis because epilepsy, if we have only epilepsy, it's not without any other neurologic or extra neurologic signs. It's less likely that these seizures due to metabolic disorders. And mechanism of metabolic disorders, one of the mechanism of metabolic seizures, this is accumulation of toxic metabolites, for example, ammonia. We can see hyperammonemia in some metabolic disorders such as fatty acid oxidation disorders or mitochondrial disease, and hyperammonemia leads to swelling of astrocyte and brain edema. Another metabolic disorders leads to seizures due to disruption of neurotransmission. For example, glycine encephalopathy. Hyperglycemia leads to overstimulation of NMDA receptors, and this leads to seizures. But sometimes we have energy deficiency in mitochondrial disease or fatty acid oxidation defects also, and we know that glucose is the main source of energy for brain, so energy deficiency also lead to seizures. And at last, some metabolic disease is associated with structural brain malformation, such as polymicrogyria in paroxysmal disorders that also leads to seizure due to neural circuit disruption. And where we consider metabolic epilepsy. If we have unexplained metabolic seizures, early myoclonic epileptic activity with hypsarrhythmia, unexplained hypoxic ischemic encephalopathy, refractory seizures, seizures related to fasting, stress, or food intake, or food intolerance, especially protein intolerance, and seizure associated with developmental delay, failure to thrive, and episode of lethargy and vomiting. If we have parental consanguinity or when seizure associated with family history of seizures or unexplained neonatal death, seizure associated with abnormal head size or cause and dysmorphic facial features, unusual odor or retinal or lens abnormalities, organomegaly, dermatitis, and hair abnormalities. And at last, seizure associated with metabolic derangement such as metabolic disease, metabolic acidosis or hyperammonemia, hyperlactatemia, and hypoglycemia. Also, in this case, we think about metabolic seizures and encephalopathy. And different metabolic disorders have different abnormalities in EEG. For example, for untreated phenylketonuria, sometimes we have hypsarrhythmia. For molybdenum cofactor deficiency, we can see burst suppression pattern on EEG. And laboratory indicators also help to diagnose some metabolic disorders. For example, increase of uric acid we can see in glycogen depot disorders or fatty acid oxidation disorders, mitochondriopathies, but decrease of uric acid we can see in molybdenum cofactor deficiency. And in organic acidemia we can see metabolic acidosis. And now I start report. This child is from second pregnancy and the first delivery. The mother's age 23, father's age 29. The parents are closely related, being first cousins. The mother's was carrier epilepsy, and she has a history of congenital sibling deafness. The first pregnancy ended in miscarriage during the second month of gestation. The current pregnancy was complicated by anemia and thrombophilia. The child was delivered by via cesarean section. Gestational age was 37 weeks. Upper score at first minute was 6 and 7 at 5 minutes, and the birth weight of this child was 3.1. On the second day of life, the infant, this newborn was transferred to our hospital in the NICU department because of prominent neurological symptoms. And seizures of this child was refractory. First ultrasound on the second day of life performs shows cerebral edema and signs of impaired cerebral blood circulation. Second ultrasound performed on 27 days of life already revealed a dynamic ultrasound, significant ventricular megacisterna magna, and increased echogenicity of periventricular deep white. Next ultrasound, we see already increase of ventricular metric, and then we see we perform this ultrasound several times, and next ultrasound revealed periventricular lake hamalacia and corpus callosum against hypoplasia. Metabolic screening without any pathology, the blood ammonia level was a little bit higher than normal range, and audiological examination performed on since this is what 6 weeks of life, confirmed normal hearing, and this patient was examined by neurologist at the diagnosis of neonatal hypoxic encephalopathy with seizures was made. Treatment with phenobarbital and Epinex was initiated, and I want to say that treatment of epilepsy changed several times because of refractory seizures. The infant discharged at the age of 1 month, and on the 5 weeks of life, electroencephalography (EEG) was performed and show high amplitude sharp wave and spike slow wave discharge in both frontotemporal regions, occurring every few seconds. The results indicated a focal epilepsiform abnormality in cerebral bioelectric activity originating from the cortical zone. And considering the delay in psychomotor development, lack of eye contact, the close familial relationship of parents, and so after that, peripheral blood sample was collected from the patient for molecular genetic analysis, and results of exome sequencing received confirmed diagnosis of molybdenum cofactor deficiency A with a deletion in the molybdenum cofactor deficiency S1G. Molybdenum cofactor deficiency is a severe metabolic neurodegenerative disorders inherited via autosomal recessive pattern. It characterized by refractory seizures, facial dysmorphism, significant neuropsychiatric retardation, and early mortality. This disease resulting from mutation in molybdenum cofactor deficiency S1, S2, and GPHN genes, which are involved in biosynthesis of molybdenum cofactor and the synthesis-dependent enzymes. Mostly we can see this disease in South America, South Africa, Central and Eastern Europe, Asia, and Turkey, and affecting men and male and female equally. And this why we have this size. Molybdenum cofactor is need to proper work of 3 enzymes. One of them sulfite oxidase, another aldehyde oxidase, and xanthine dehydrogenase. If we have molybdenum cofactor deficiency, this leads to sulfate oxidase deficiency. So this leads to accumulation of sulfite in brain tissue and neurological symptoms. Neurological the damage of toxic damage on the human. Sometimes we can early, but sometimes late onset of molybdenum cofactor deficiency. In 90% of cases, disease present in the first days of life and present with severe encephalopathy, seizures, epistatonus, axial hypotonia, and appendicular hypertonia, feeding difficulties, and apnea. And also the cranial dysmorphism is observed. This is triangular face, wide nasal saddle, shortened bifrontal diameter, full cheeks, and long eye slits, cleft soft palate. This clinical manifestation and neuroimaging findings resemble those of hypoxic ischemic encephalopathy, but molybdenum cofactor deficiency present with more aggressive neurological symptoms and have positive sulfite taste in urine and decreases uric acid level in serum and And in molybdenum cofactor deficiency, prenatal and birth history is unremarkable, and approximately 40% of patients has upper score at 5 first minutes below than 7, with subsequent improvement observed in 5 and 10 minutes. The absence of significant perinatal complication and the lack of immediately postnatal symptom onset help differentiate molybdenum cofactor deficiency from neonatal hypoxic injury. In the first days of life, the hypoxic ischemic encephalopathy and molybdenum cofactor deficiency has the same change in cranial MRI. This is loss of differentiation between gray and white matter and edema of the sulci. But after some times, radiological features of molybdenum cofactor deficiency differentiate it from hypoxic ischemic encephalopathy. This is metasternum magna, hypoplastic or atrophic corpus callosum or cerebellum, congenital signs of prenatal brain degeneration. This is cortical atrophy, cystic leukoencephalomalacia, degeneration of the basal ganglia, and damage to the caudated nucleus. And however, the absence of this radiographic findings does not rule out molybdenum cofactor deficiency. Cranial ultrasound of our patient the first days of life showed the presence of brain edema. In follow-up neuroimaging, marked ventricular megaly, megasternum magna appearance, and hypogenesis of the corpus callosum were detected. And typical how we make diagnosis, based on typical MRI findings, high concentration of sulfite, increased level of L-sulfacysteine, xanthine, hypoxanthine in the urine, and low concentration of uric acid in blood. Blood and genetic testing is essential for an accurate diagnosis. The parents of the affected child, usually they are carriers, and each of them has one normal and one defective gene. Conclusion, our patient genotype examination revealed a novel deletion in molybdenum cofactor deficiency S1 gene. The impact of this mutation on the patient survival is currently unknown. And our patient died at 3 years old, and the median survival for molybdenum cofactor deficiency is reported to be 36 months. And certain mutations are associated with delayed postneonatal onset and longer survival. And what about treatment? Modern treatment of molybdenum cofactor deficiency. This is a lifelong infusion of purified cyclic pyranopterin monophosphate, but this is very expensive treatment, and this is about $500,000 for years for every patient, sometimes more than this one. And so our patient, and this medication we can use only in molybdenum cofactor deficiency S1 type. So we did not use this medication, cannot use this one. And unfortunately, our patient died. This is doctor of our patient. And at 3 years old, already we lost this patient. Thank you for attention.
Well, thank you, John, for the signature. Yeah.
Thank you very much.
So to have a session of the day, our last poster listener is Dr. England Denise Maria from Pediatrics. The poster is titled Basic Surgery in Pediatric Patients, Current Status and Future Directions. Please welcome Dr. K.
Hello, everyone. First of all, I want to thank you for invitation. I'm glad to be here. My name is Denisa Maria Canuț. I'm pediatric surgeon and professor assistant in Bucharest, Romania at Bucharest Academic Hospital. Today, I choose to speak about minimal invasive surgery in pediatric patients because this is the future of technology. Thank you. First, I want to make an introduction, methodology, study objective, result, and after all, we talk about conclusion. Over the past few decades, pediatric surgery has undergone a major transformation from large incision and prolonged recovery times to intervention performed to mere millimeters of access. Minimally invasive surgery promises a revolution, less pain, reduced biological stress, and faster recovery. Current challenge. However, this technological revolution raises several critical questions. Can a minimally invasive surgery be safely applied in newborns and infants? How can surgical instruments be adapted to fragile pediatric anatomy? Or is robotic surgery a genuine solution or merely an expensive trend? What training and access barriers exist in smaller centers or in resource-limited countries? As of 2024, only 35 to 40% of pediatric centers in Europe possess full infrastructure for advanced minimal invasive surgery, including robotic systems, single port technique, and micro-laparoscopy. Over 60% of pediatric surgeons report a lack of standardized training in neonatal minimal invasive surgery. To assess the current status of minimal invasive surgery in pediatric practice by analyzing recent literature and identifying future direction for clinical and scientific development. Specific objective: to analyze the level of implementation of minimally invasive surgery across internationally, including laparoscopy, thoracoscopy, and robotic surgery. I don't have. I think it's problem. It's a problem with connecting. Maybe I need to check. You need to check here.
Yeah. I think you can disconnect.
Maybe you try again. Sorry for this.
Disconnected.
I can hear. No? Sorry, we start again. To compare clinical outcomes.
Maybe it's okay. Technical problems. Sorry. Yeah. You don't have any option. One moment. Okay. You don't have any ports, other port? Maybe we are lucky. Yes.
Yeah.
Okay.
Rights and limitation of minimally invasive surgery in relation to patient age, type of surgical procedure, and the level of available technology to identify gaps in professional training and barriers to the adoption of pediatric minimally invasive surgery, including technological, economic, and educational challenges. To propose future research and innovation pathway focusing on instrument miniaturization, the development of pediatric specific robotic system, and the integration of artificial intelligence into surgical guidance. Pediatric minimally invasive surgery provides clinical outcomes that are comparable to or better than traditional open approach. However, its development is currently constrained by technological, economic, and educational factors. Type of studies analyzed. This review is based on a rigorous selection of retrospective and prospective comparative studies assessing the efficacy and the safety of minimally invasive surgery compared to open surgery in pediatric patients. Systematic meta-analysis and narrative review published between January 2020 and September 2024 incorporating multi-center data from patient pediatric from pediatric surgical center in Europe, North America, and Asia. Multi-center observational studies and large case series used to supplement missing data for rare pathologies, esophageal, congenital diaphragmatic hernia, robotic pyeloplasty. Our criteria: population, pediatric patient under 18 years of age, including neonates, infants, children, and adolescents. Surgical intervention, abdominal, thoracic, and urologic procedure via minimal invasive approach, laparoscopic, thoracoscopic, or robotic. Comparators, a procedure performed via conventional open surgery conducted in the same center and within comparable time frames. Reporting criteria, clear documentation of perioperative parameters, operative time, blood loss, length of hospital stay, complication, reintervention, and a minimum postoperative follow-up period of 30 days. Exclusion criteria: studies with fewer than 10 patients, absence of a controlled group, incomplete database, duplicate publication. We evaluate indicators. For each selected study, the following key parameters were extracted and compared. Duration of surgical intervention, used as an indicator of learning curve and technical complexity. Intraoperative blood loss reflect the degree of tissue trauma and the technical precision. Length of hospital stay serve as a marker of functional recovery and the occurrence of postoperative complication. Rate of complication and reintervention include conversion to open surgery, time to oral feeding resumption, a major clinical endpoint in pediatric surgery. And now we have the results. The duration of the surgical intervention, comparative analysis of studies published between 2020 to 24 show that the duration of procedure performed without minimal invasive surgery is, in general, longer than in traditional open surgery. Difference vary depending on the type of intervention and the operator's experience. Laparoscopic appendicectomy, we have one example, plus 10 to 20 minutes compared to open surgery. Laparoscopic robotic pyeloplasty, plus 30 to 45 minutes. Complex procedure, esophageal atresia scoliosis, plus 60 to 120 minutes. The increase in operative time is explained by the limitation of 3D visualization and manipulation in confined space. The need for additional time for port placement and instrument preparation. The learning curve of pediatric surgeon in minimal invasive surgery. As team gain experience, the duration of the intervention decreased significantly. The difference compared to open surgery becoming statistically insignificant after approximately 50 to 100 cases performed per center. Like I say, the more you practice, the better you become. Results. Observed trend, as team gain experience, the duration of the intervention decreased significantly, the difference compared to open surgery becoming statistically insignificant after 100 cases. Intraoperative blood loss, all analysis studies show a significant reduction in blood loss in pediatric minimal invasive compared to open approach. Mechanism amplified the visualization of vascular structure, more precision coagulation, and selective dissection. Avoidance of front handline of tissue and advanced organs. Here we have in this slide parameters and time operative blood loss transfusion requires for open surgery and for minimal invasive surgery, and we have a relative difference. For operative time, we have plus 10 to 50%. Blood loss 50 to 7%, and transfusional requires not significant. Now we have overall complication rate, 10% similar to open surgery, and like observation, minimal invasive surgery has a comparable safety profile. Most frequent minor infection and anastomotic legs. Reintervention rate, 3 to 5%, no statistically significant difference. And observation, most in reintervention are minor or endoscopic conversion to open surgery in 1 to 3% of cases. Intraoperative conversion, 1 to 3% of pediatric minimally invasive cases, usually related to unexpected bleeding or poor visibility. Overall safety risk profile comparable to classic surgery. Clear benefits: reduce tissue trauma, February infection, shorter hospitalization, and pediatric robotic surgery. Outcome similar to conventional minimal invasive surgery, but with superior precision. Example: robotic pyeloplasty, hernia repair, treatment of colorectal chest, mini laparoscopy, and single port. Instruments like 3 millimeters, almost invisible scare, ultra rapid recovery, indicated in neonates and infants, aesthetically and functionally superior, but technically challenging because we don't have enough space. Technological perspective: instrument miniaturization, AI integration, and augmented reality in surgical navigation. And next stage, intelligent guide surgery with 3D visualization and happy feedback. In conclusion, pediatric minimal surgery offer clinical outcome comparable to or better than open surgery. Demonstrated benefits: reduce trauma, minimal pain, faster recovery, shorter hospitalization. Complication and reintervention rates are similar to traditional approach. Standardized surgical training, like a recommendation for practice, develop technological infrastructure, create nation international registries to monitor minimal invasive surgery outcome in pediatric. And future direction: multi-center randomized studies comparing minimal invasive surgery versus open surgery for specific pathologies. Miniaturization of instruments and development of dedicated pediatric surgical report. Here we have instruments like 8 millimeters, not 3. Integration of artificial intelligence and augmented reality for intraoperative guidance, real-time analysis, and complication protection. Long-term impact assessment on growth, development, and quality in life in children. Thank you. Thank you. Okay.
So we have come to the end of day 2. Thank you to all our listeners and attendees for making this session so enriching. Your dedication and participation truly reflect our shared commitments to improving the health and well-being of children.